Uganda's digital and healthcare specifically transformation. So the ministry is fully committed to supporting the endeavors of the hub. The ministry will continue to work closely with the hub to strengthen policy frameworks, facilitate research, enhance access to digital infrastructure. I want to emphasize that necessary for scaling the AI-driven healthcare solutions, but additionally, the ministry will also explore funding opportunities, partnerships, and capacity building initiatives to ensure that the hub remains at the forefront of AI-driven innovation in healthcare. I would want to note that beyond the partners that you have, we can have more partners. For instance, I talked about International Telecommunications Union. We already have a partnership with the JICA, Japanese International Cooperation Agency, and they are really focused in the area of what? Of AI and data science and robotics and other digital-related technologies. So these are things that we shall look at ensuring that we expand and be able to support the initiatives further on. What's our call for collaboration? Of course, today's symposium is an exemplifier of the power of collaboration by bringing together, of course, the different partners and stakeholders like academia, government, industry, international partners, but also the civil society. Is very, very important to ensure that the AI technologies are developed responsibly and deployed effectively. So let us all leverage our collective expertise to create AI systems that not only are intelligent, but also just and compassionate. I want to conclude by further reaffirming the ministry's unwavering support for the initiatives that harness AI and data science to improve healthcare outcomes. Together, let us navigate the challenges, seize the opportunities, and chart a course toward the future where technology serves as a beacon of hope and healthcare. I want to thank you very much for God and my country, Dr. Frederick Edward Chitogo. Thank you.
Another round of applause for Dr. Chitogo. He's doing great work at the National Hub in Nakawa, and they always invite us as Mbarara University to be part of them. Thank you so much for always coming whenever we call you upon. Ladies and gentlemen, allow me to welcome and recognize the only ophthalmologist who doesn't wear glasses. Dr. Arunga Simon is in the house. Please stand up for recognition. He's the only one who doesn't put on specs, and he always gives us specs when our eyes are sick. Allow me to welcome and recognize Dr. Muganzi David, a former student of Mbarara University, but a great innovator who has been recognized at national and international stages. Please stand up for recognition. A person who brings smiles. Mainly, we had a debate that obstetricians were saying, we bring smiles. Then there was a great debate, even the pathologist was brave to say, we also bring smiles. And then we had all the others, but allow me to welcome and recognize Dr. Dora Nampija, a cardiologist, who brings smiles to kids with cardiology problems. She's a great researcher. She has written grants that have saved many babies, and we acknowledge that as a university. Thank you so much. Allow me to welcome and recognize ICT personnel, who is a brain behind most of the innovations at Comtech, Mr. Mukama Martin. Thank you for being with us. Yes, ladies and gentlemen, before the next speaker, I'm the only person who's going to get a degree of medicine because I've associated with doctors. And God's people said, those who wish me well said. Yes, the dean is here. He might confirm me the degree of medicine by association. It's unhealthy for us to sit for long, and we need to stretch ourselves and recognize that we are healthy. Allow me to request you to stand up, please. Just stand up for me, please. Thank you. Yes, people are already shaking. Give me a paper. Just give me a paper, please. Yes, you have one for me. Put it at the back of your neck. You have it? That's already a stretch. Get the arm that you use, the arm you used to write. Get a pen or pencil. Now face your neighbor and start drawing their face. Draw this. Yeah. We're going. Do the face. Do the circle. Do the circle. No, you're drawing on your paper. Face each other. Face each other. Okay, draw the circle. Draw the face. You're facing her. No. Yes. Okay, draw the circle. Put the ears. Put the ears. Oh, come on. Stretch the hand. You're facing him. No. Hold the paper. Yes. Start drawing the circle. No. You're drawing on your neighbors. Use your hand to draw. Face him. Okay. Yes. Now draw the circle of the face. Face each other. Face each other. Yeah. Okay, so put the ears, put the hair if it's a lady, put the glasses. Come on, why are you poor artists? You can put the lipstick if they have it. Now show them the picture. How do they look like? Aha. Those are your friends. Those are your friends. Please take a seat. Yes, that's how people think you look like. Can you imagine? Ladies and gentlemen, she is a professor of medicine at Harvard Medical School and an internist at Massachusetts General Hospital. She serves as a director of research at Global Health Collaborative Center at Global Health. Dr. Jessica is also a principal investigator for Mbarara University Data Science Research Hub, focusing on data science application in global health. Her focus has always been that she focuses on issues that are related with clinical epidemiology. And I'll take that again. Her multidisciplinary research integrates clinical epidemiology, behavioral science, mobile health, implementation science. I'll say that again, implementation science. And I'll appreciate if she gives it a highlight for our students to appreciate implementation science. She also focuses on health and aims at enhancing HIV, AIDS, and tuberculosis prevention and treatment. Ladies and gentlemen, the couple of times she's been in Uganda, we appreciated her and gave her a Ugandan name, Agaba, because she gives a lot. We gave her a cow. She couldn't take it to the US and chose to share it with us in form of writing grants and helping us with research. Ladies and gentlemen, let's welcome Professor Jessica Mbarara Agaba.
Good morning, everyone. It's always nice to speak after Angela makes us exercise. So I hope everyone is alert. And can we go ahead and start the presentation? So I'm actually going to take the speaker's privilege and give you 2 talks in my allotted time. So we will start with implementation science, and then I will pivot to talk about the village, which you heard a little bit about earlier. Are we able to go into presentation mode? Okay, while that's getting ready, who here does implementation science? Stand up, let's be proud. We have 1 person? 2? Yes? Some of you, yes, some of the team. How many have never really heard of implementation science, or if I called on you, could not give me a definition? I see a couple of brave people. Okay, so it sounds like we have a little bit of experience, but a lot of opportunity to learn about implementation science. Okay, maybe I'll just wing it. So until the technology works. So implementation science is in some ways similar to what many of us have done in clinical research for many years, but in some ways it's different. And I think one of the most important things about implementation science is that it helps us do more with what we know. So a lot of research is geared to understanding if something is efficacious or effective. You're trying to figure out if this intervention will help somebody, or maybe it'll improve some process that you're trying to study. But with implementation science, what we're doing is really trying to understand how evidence-based interventions or methods can work in routine practice. And so the concept, I guess I will just wing it. So the concept is really about knowing how to do what we already know works well. I'm going to grab my slides and then I'll just talk through them. Okay, so as I said, we're going to talk about implementation science, and I want to make sure that everybody's on the same page with what we mean by that. And then I want to talk about how it relates to data science. And then I'll talk a little bit about how we're using it in Mudsy specifically, and just a few parting words. Okay, so as I've mentioned, data science is really about the study of methods and strategies to use things that we know work. It can address this know-do gap, which means we know how to do things, but we don't necessarily actually do them. So we want to try and bridge that. And it really addresses barriers and other things that slow the implementation of evidence-based interventions. So this cartoon's a little bit fuzzy, but I think it really embodies what we're trying to do in implementation science. So if you can't read it, it says the latest research shows that we really should do something with all this research. Okay. And I think this is really critical when we think about perhaps a drug that is discovered in a laboratory. By the time it actually reaches a patient's mouth, the average time is 17 years. And that's much, much too slow. We have too many problems out there that need to be actually improved upon. And also, if we don't pay attention to how interventions and other innovations are implemented, there will be a lot of inequities that could be avoided. And I'll talk about that in a bit in more depth. But there's a running theme that you'll hear a lot throughout the symposium on equity, and implementation science has a big part to play in that as well. I think I've covered this earlier, but just to kind of clarify the difference between implementation science and intervention research, you can see here that the aim with implementation science, again, it's not to develop new knowledge about something. We can call it a widget, we can call it an intervention, but it's really about a strategy to get that used. And that's different than intervention research. So the outcomes, whenever we design a study, we want to know what is the outcome that we're looking for. The outcomes are going to be more about things like acceptability, adoption, appropriateness. Like, how well can we use this thing that we know actually could improve someone's health? Whereas in intervention research, it's more about that effectiveness, safety, maybe changes in mental health, changes in behavior. So it's similar in ways, but really different in others. And the unit of analysis may be different. So in our clinical trials, we may be looking at somebody who's receiving a drug, but what we're looking at here in implementation science may be, how is the clinic using that medication? Have they adopted it? Do the patients see this as acceptable to receive the medication in this way? And there are three kind of overarching principles that I'd like to tell you about in implementation science. So the first is to describe or guide the process of translating research into practice. So try to keep that in mind, research into practice. This is a different type of translational research, but again, very critical so that we can use the evidence-based interventions that are out there or that maybe you're working on. Implementation science can also help us understand or explain what influences that process of implementation. And then we want to use these methods to actually evaluate how has that implementation gone. So this is a little bit of a busy slide, but I borrowed it from the University of Washington, which has an not be able to see from the chairs, but hopefully these slides will be available to you. So within implementation science, there's a pretty robust rigor to understanding which methods make sense when. And so there are ways where you could think about the process of implementation. Maybe you want to determine those factors that may influence whether you can implement a strategy. There's some classical theories. I'll go through some examples in a minute. You may want to understand more about how to evaluate what's happening. So there's a rigorous approach to understanding how to do this in different contexts. So let me give you those examples, make this a little bit more concrete. So one implementation science framework is called the Consolidated Framework of Implementation Research. This is sort of the kitchen sink of implementation science in that it's incredibly comprehensive. So I know that the print here may be a little bit too small for you to see, but each of these components of the framework are represented by the circles and the rectangles. And basically what this does is give you a framework to say, what are the factors, what are the domains that I should be paying attention to? It actually has like 74 different things you could think about, but you don't necessarily have to look at all of those, but you can choose what's going to be most relevant for my context. So you may want to look at the outer setting, and that's my pointer works. No, the outer setting is that bigger circle. So how does my intervention, maybe I have a screening algorithm for, let's say, diabetic retinopathy. How is that comparing to other priorities that may be in ophthalmology or maybe in the Ministry of Health when it comes to providing ophthalmologic care? What's happening in the inner setting? So if the clinic is very busy, they need something that's going to be implemented quickly, I need to take that into consideration as I'm developing a strategy for implementing that algorithm. There may be individual characteristics that you need to pay attention to, characteristics of the actual algorithm, you know, what is important for this context and what is not, and then what is the process of actually getting it used. So it's actually a very, very helpful model. Another one is precede, proceed, which I like because it helps you think about the planning stages as you're developing the intervention, even though we're focusing, the strategy. So we are focusing on both determinant factors here as well as process. So I may need to look at what's going on socially, epidemiologically, educationally, or administratively that could influence my ability to implement an intervention. And then I measure that by understanding what actually happened, what was the process like, what was the impact, and what were those outcomes. So this one's a nice comprehensive overview. And then this one is called REAIM, which is one of the probably longest used implementation science frameworks. I'll tell you a little bit more in a minute about how we're using it in Mudsy. But this is a very good evaluative framework so we can understand what is the reach of the intervention, who's actually receiving it. How effective is it in the implementation context? We know maybe how something worked in a trial, but how's it actually working in the clinic? There's adoption, so is it being taken up in the way we think? Are the nurses providing it? Are the doctors providing it? Implementation, like how is it actually being delivered? We may want the algorithm to be used a certain way, but maybe it's actually being used differently, and that's really going to influence our outcomes. And then finally, how well are we able to maintain what we're trying to do with this strategy over time? Because if it stops as soon as we leave, it's not really accomplishing our goals. I also want to give you mentioned before, then we also have these strategies which indicate that the systems environment, the organization, different types of learning approaches, maybe people need to be supervised. These are different strategies for getting interventions implemented, and then we can see what their outcomes are. This is another list of different types of strategies that you may think about to improve adoption. So you could do something like audit and feedback. Like, are the clinicians actually using what I want them to use? And so I look at that, and then I feed it back to them in a way so that they can understand, are they actually using the intervention the way we want them to? So it sort of gives a level of accountability. You could look at tailoring something. Maybe you need a little bit of adaptation. Maybe you need some in-service trainings, whatever may work in your setting, but the implementation science field is geared towards giving you the rigor, the methodology, the tools to understand which of these strategies or which combination of these strategies are really going to get that evidence-based intervention into practice. This is another way of thinking about it with the strategies, that you may need to think about messaging. How do you explain the intervention to the community, to the clinic? How do you deliver it, and how do you support it? And then finally, with study designs, in trials, we may look at a randomized controlled trial. We may want to do a cohort study. There are many different approaches that we can use. With implementation science, we think about it in a couple of different ways. So you may do something like an RCT or a cohort where you're observing the implementation and seeing how those strategies work. But you may also mix it up a little bit, where you're working together with the more traditional approach, like an effectiveness trial, but you're studying the adoption along the way. So those are called hybrid designs, and it may be that you're focusing a little bit more on the implementation and less on the effectiveness, because you have a lot of confidence in that evidence base. Maybe you're balanced, and that would be the type 2. The other one was more of a type 3. And then the type 1 is where you're focusing more on the effectiveness and just kind of tracking the implementation as you go. So putting all of this together, there's this nice model called the Implementation Research Logic Model, where each one of those components is put together in this diagram, as you see here, to show how you start with the evidence-based intervention at the bottom here, but you have all of these factors that are kind of coming into play as to whether the intervention will be taken up. Then you want to think about those strategies. Would an audit and feedback system help here? Maybe I need to do some other kinds of in-service trainings. What are the mechanisms by which that strategy is actually doing what we hope it to do? And then what are those outcomes? Does that result in acceptability? Does that result in adoption? So this is kind of a bird's eye view of what we're trying to do with implementation science. All right. So that was our primer on implementation science. I know that's a lot in just a few minutes, but I hope that gives you an overview of what we're talking about when we say implementation science. Now, how does this relate to data science? So with data science, I showed you before those 3 kind of principles about implementation science. How does that translate into data science? So just like any other intervention, we can think about the tools that we are developing through data science as an evidence-based intervention that we need to implement into a clinic or into a program. So this is making implementation science usable and relatable in practice. And so we don't just spend our time writing code and developing algorithms that nobody uses. Like, none of us want to do that. We want this to actually have an impact. So implementation science is a method for achieving that. We can use it to evaluate the influences and the use of algorithms, just like you would with any other evidence-based intervention. And this is really important for that bias issue that we've been peppering into our discussions already, and we'll be getting into more depth as we go through the symposium. And then finally, increased use of this data will address some of the inherent bias if the data science is not coming from areas like Uganda. Right now, only about 2% of all data science is coming from the African continent. That itself is leading to a ton of inequity. And if we increase the implementation of what is coming out of projects like Mudsy, then that will increase its relative contributions to data science and address the inequities while we're looking at more benefit for individuals using it directly. Part and parcel of implementation science is connecting with stakeholders, and I think this community is so fantastic in its varied background and also its ability to work together in a multi-collaborative fashion. So you can see all of the folks that are here. I won't read through them for sake of time, but I think this morning we've been able to appreciate how each of us is coming from a different perspective and has so much to offer in the context of data science, and that will further the implementation and ultimately impact. So let me get specific about what we're doing in Mudsy to adopt all of these different tools and how we hope it will increase the impact of what we do and hopefully lead to future projects and future impact. So as I mentioned, we want to integrate what we're doing with the community. This is not a project that stays within Mbarara. It doesn't stay within our collaborators, whether that's in Boston, in Ghana, Kenya, or elsewhere. This is something that we want to make part and parcel of the Ministry of Health, of industry, of anyone who wants to use these tools in the community. So we want to be very intentional about that, even as we're still developing the products that we ultimately want to have from Mudsy. We think this will increase our ability to work together and to reduce silos, and it will really, I think, help create pathways for future development. So you've already heard a little bit about each of our projects, so I won't review them in great detail, but the AviMap project is the first one I'd like to highlight. I did put a picture of the cervix, Fred, I hope that's okay. So basically, again, we're trying to develop algorithms for diagnosing abnormalities with the cervix. And we are using that re-aim framework once we're able to have the practical application of the algorithm so that we can understand not just whether the algorithm is accurate, which is where a lot of data science stops, but is it reaching women? Like how many women have pre-invasive disease that we're able to identify with these tools? That's telling us how it's going to be able to have an impact in the community. We want to look at the adoption. So how many of the clinical sites are using the tool for screening? Again, we want to know if this is making a difference, not just if we produced it. Is it being implemented as we think it should? Is that any change in the process of implementation? And are we able to sustain that impact? Again, if it only lasts as long as we're watching it very closely, we won't have the impact we're looking for. The other major project that we've been working on in Mudsy is Modria. We're also doing many pilots. I just won't be going through each of those. This is the project looking at retinopathy, and we're evaluating the feasibility, appropriateness, and acceptability of the algorithms with that Proctor framework that I mentioned before. So I think these are nice examples of how implementation science and data science can work together. And I think we're one of the few projects out there that is recognizing the importance of this step of development, because much of data science often is focused only on the data piece and not how it's being used. So looking to the future, data science, I mean, this is kind of speaking to the choir here. It's a part of everything we do. And if we don't pay attention to how we contribute to developing it and how we end up using it, I think we're going to have a lot of problems, specifically around equity, but also just in how we're using data science in general. And I think there's a ton that we can do to try and break down those potential problems with AI by thinking about how it's being used, even as we're developing the tools themselves. So I'd just like to thank so many people on the team, the NIH for our funding, and Dr. Steve Bartels, who was at the prior symposium last year, but who's an implementation science and helped me with this presentation. So I will pause here and see if you have any questions about implementation science before moving on to the second talk. So thank you for your attention. I'd be happy to take a question or two if there's time. Do we have any converts? Is anyone interested? I think we have one over here. Do you want to just speak up?
When you introduced your talk, I was initially talking about some of the reasons why it takes 17 years.
Yeah.
Also, you have drug pharmacies. Yeah. So why it takes that long? Some of the reasons it takes that long. And sort of how to go around them, because I can imagine even if we had 99% AUC performance on detecting algorithm, we just don't implement it at must. There are certain guidelines that we have to, some approval that we need to get before we do that.
So that's a perfect question. So what I would do to answer that question is go back to what I was talking about with the frameworks, the models, and so forth. And I would use something like a determinant framework to understand what are the factors that are determining the process of the rollout. So why is it taking 17 years? And I could combine that with the CFIR, that model where we're looking at outer setting influences. Is there something about competing priorities at the ministry level? I could look at the inner setting. Maybe people don't understand how to use that intervention. I could look at the intervention itself. Is there something we can change slightly that would make it easier? Is it the packaging? Is it the way the nurses are providing it? So, and we can also look at the process. Is the supply chain failing at certain points? Do we need to look at different manufacturers to get a generic versus a branded drug? Things like that. So there's not one answer as to why it takes 17 years, but I think it's a really good rationale on why this is important, and I hope I've inspired many of you to think about implementation science in the different types of work that you do, because there's a lot to learn here. And some people even say that if we didn't discover anything new, but we just learned how to use what we already know, our health would potentially be equally as improved, because we sit on so much evidence of effective interventions, but we just don't use them. Let's take one more, and then I think we'll probably have to move on.
Thank you so much, Dr. Jessica. I'm David Jolie. I'm a medical doctor working at the bridge of industry and academia, and that's where my question is coming from. I've just been introduced to the folks in our industry, and the way they look at putting tools out there is shipping fast. We have to ship so fast, and we learn as the people use the tools, and in a way they move a little faster than people from academia. But we know that from academia we get effective ways of putting out the knowledge. I just wanted you to comment on how to take the speed from the people in industry, but at the same time the effectiveness of the people from academia. Because we see implementation science is very important, but when you go out, for example, you have a startup, it may not be easy to run the studies, because of resources. Thank you.
Yeah, thank you for that question. I think it's really perfect for what we're trying to do here today. So this audience has a mixture of academics, industry, and other partners, and I think there's a lot we can learn from each other. I dabble in both worlds myself, so I know what you're speaking of. And industry sometimes learns by doing. They want to break whatever they're doing quickly so they can fix it. They have rapid iterative cycles. Almost nothing happens rapidly in academics. That's just part of how we are. But we do also generate key knowledge that then gets applied in industry. And part of the knowledge that we generate from implementation science can then guide the next startup. It can guide the next rapid cycle that industry may then take advantage of to get products out more quickly. So I think there's a lot to learn from each other. And just as a short answer to your question, I think we need to embrace that much more than we have. Maybe that's a silver lining of all the craziness that's going on right now in the world, and that we need to diversify how we think about developing knowledge. And some of that may be through industry partners when traditional funders are no longer working the way they have before. So I think the short answer is we need to work together. Okay. Thank you very much. And as I said, I'm going to take the speaker's privilege here and switch gears to talk about something I feel even more passionate about than I do implementation science. So can we switch to the other talk? So while he's pulling up the slides, who in the audience has heard of The Village? Come on, everyone's being shy. Raise your hands. A couple of people. So I hope you saw when you came in, there's a QR code to learn more about it on our website. But I will be giving you the background on what The Village is and why it ties in so closely to what we're talking about during this symposium. maybe I'll start by winging it. So the Village, essentially the Village is a digital platform to support mentorship, collaboration, and ideally innovation. It's built on a philosophy, the Ubuntu philosophy, that I am because you are, and that by bringing people together as a community, we're able to support each other in ways that we couldn't if we didn't have that opportunity to connect. And I'm sure many of you have used LinkedIn, other kinds of platforms where you have connections, but those connections often stop at the connection point, and they don't necessarily move on to the products of what you would like to get out of those connections. So the Village was born, I would say, about 3 years ago. Maybe it depends on how you think about the development. But it was born through me and through my co-founder, Professor Yap Boom, who I think many of you may know. And it came out of a lot of frustration around inequities in the ability for people to develop their careers. If you think about talent in the world, it is not isolated in certain geographies. Talent is universal. Many people have things that they can offer to the world, but they never have the opportunity to do so. And some of the people who have those opportunities may not even have as much to offer, but they are built upon a legacy of opportunity through connections, through educational opportunities, through many things. And the Village is really trying to level the playing field in a way and to think about bringing more equity to opportunity. So we infuse all of this with AI, which is one point of connection to this symposium in particular. So I'm going to quickly go through this because I gave you the brief background already about why we need the Village, and I'll tell you a little bit more about what exactly it is, and then give you the opportunity to join. So as I said, we all know this, many inequities exist in the world. I'm focusing here on global health because we're a health community, but this could apply to anything, to business, agriculture, you name it. So we need to do something about this. And as I said, some of us in the room actually, and these are some names you may recognize, started thinking about these issues about 5 years ago in looking at the inequities and thinking about solutions. And one of the major ones is mentorship. Mentorship is so critical. I certainly wouldn't be who I am today without reflected by electricity here. This is why we have the Village. Reflected by electricity here. This is why we have the Village. This is why we're trying to make opportunities where they don't exist. So Professor Boom gave a talk about some of these issues when he was in Boston a few years ago that really kind of set off a catalyst of trying to figure out what we could do and ultimately developing the Village. And I think, the main motivation here is to help people broaden their horizons. And I put this flag, the South African flag here, as a reminder of a story that I learned about through Trevor Noah. Everybody knows Trevor Noah, South African comedian. He wrote a fantastic book called Born a Crime. And I highly recommend it if you haven't read it already. But there was one very poignant moment in that book where he was talking about a really smart young man. And this smart young man was very hardworking, he was dedicated, he had all the tools for success. Somebody who could really make it and make a difference not only for himself and his family, but really for the world. But the only thing he could imagine to do with any opportunity was improve the door on his compound. Nobody opened his eyes to what he could do with his talents. All he could think about was what was immediately in his circle. He didn't have a mentor. He didn't have somebody to help harness that potential. And that story has really stayed with me because there are so many people who are like that young man. So Professor Boom and I started to develop different mechanisms for addressing these issues through the academic system, through working with funders. We're working on this problem in a variety of ways, but the Village really represents the tangible product of how we can think about this on an individual level and what we're hoping that you all will join us in doing. So as I mentioned, we're trying to create opportunities through a digital platform, and it's sort of like LinkedIn in a way, but you blend it with Tinder. And if you don't know Tinder, I see people who are smirking know what Tinder is. It's a dating app. So we're not necessarily suggesting those kind of relationships, but we are hoping to harness the ability of that AI to match people in ways that really resonate with what they're trying to do in their lives, whether it's providing mentorship or receiving mentorship or just collaboration. I think I covered most of this already. And in addition to that, we're not just hoping to bring people together, we're hoping to use the village as a space where all of that magic can happen. So when you're working with your mentor together, what are you producing? Can you share it with other people on the village? You don't have to wait to publish it in a journal, which many of us find difficult to do. It takes a long time, it's slow, industry is much better at getting products out there quickly. So if you're working with a collaborator and you want to put your protocol out there, we can give you that opportunity and to do it with no cost. A lot of the advantages that I mentioned that come out of the connections that are happening where all those lights are on the map, people often say those are serendipitous moments when that conversation led to a degree, or it led to a new business, or it led to some other opportunity. Those are not really serendipitous moments. They are the product of connection and people coming together. So that's what our platform is aiming to do. And there are many efforts ongoing to decolonize global health, and we think this is a really strong, concrete way to do that. So there are many, many people working on the village. I won't go through all of them for sake of time, but many of them are here in Mbarara. We also have a lot of folks working in Yaoundé, Cameroon, Nairobi, Boston. So we're truly a multinational team. You can see a few others. So how are we building the village, and how can you join? So we are starting off by learning who wants to participate in the village, who could gain from this, who could contribute from this. Because as I said, this is Ubuntu. We are who we are because we are together. So we've done a number of workshops, again, perhaps with some of you in this room. We are also working with organizations. For instance, we're talking to the Pasteur Network to help organize mentorship within an institution. That's an incredible opportunity for the institution and also for us to bring people in and to start having more exchange of those products from collaboration or mentorship. And I like this quote because this comes from one of the participants in a workshop that we held last year, who said, "I had no training allowing me to choose my future. I followed a training and then sought to create. Unfortunately, I do not have the money to invest in my business, but today I am determined to find out what I want." And what I think this quote represents is, the way a lot of young people in particular go about career development is opportunistic. They take whatever comes along because maybe it'll work, but it's not what they really want. And if we're looking to harness that potential and those opportunities, we have to help people find what they really care about and enable that. And I think that's what we're, again, trying to do here. We're also developing a mentorship niche and guiding people through the connections. So the connection doesn't stop when you come together. We are building tools that help you along the way, so we can help you clarify your goals and expectations. Some of you may have heard me talk about how to do mentorship. It's a skill, and it's also, there's a skill in how to be a mentee. So helping you understand what those best practices are. How do you work together? What's a structure that's going to help your relationship be productive? How do we track what you're doing, making sure you're hitting those milestones and providing some welcomed accountability through this process? Checking in, and then ultimately celebrating your successes. I mentioned the spaces that we're creating, and we're trying to do this in a way that's powered by AI. So you could use whatever language you want to use. You could use audio if you have visual impairment. Really opening up the ability to share the science that you're creating or anything that you like to share with your community, and that you're currently not really able to do unless it's in like a journal article, and that I think is incredibly limiting. We are using a lot of different AI techniques to do this. So we're thinking about generative AI and profile creation, so it's not laborious, but can help you identify what your dreams are and how you can maybe help people achieve those dreams. Using collaborative filtering, thinking about sentiment analysis, other things that really help us get more from the data so that those matches are more successful. So if you haven't already, this is a QR code if you'd like to join the village. We're hoping that everyone here will create a profile. And then we're having an event on Wednesday, so stick around for the whole meeting. We'll have a nice cocktail, so you can meet the people that you're matching with online, and we'll ask you to fill out a very short survey, 5 questions, and maybe what could be done better. So actually putting in a little bit of implementation science in the process of developing the village. So this QR code is available also downstairs at the registration, and I think it might be circulating around. So in addition to developing the platform, we want this to be something that helps you get the most out of this meeting. As I said, that we want to develop the village for everyone, but we can use this meeting as a sub-village of sorts, where you can get more out of the people you're working with than you could have otherwise. Because your ideal partner may be sitting right next to you, and you're not talking to them. So if we can help you find each other through the village, you can continue on what you start here during the symposium. And there's a small disclaimer at the bottom. We are a work in progress. So I don't know if you can see that because of the chairs. So it will not work perfectly. I think Angela nicely explained that things don't always work the first time. In industry, you have to work iteratively. So bear with us and be patient with some of the features. But we're really hopeful that through working with you all and many other people throughout the world, we enable all of those opportunities I mentioned before. So again, the in-person meetup will be Wednesday at 5 p.m. And these are some of our sponsors. And thank you very much. I know I probably took too much time, but thank you.
The break tea is ready. But I don't want to stand between you and the break tea. While Professor Lau was presenting, one of the presenters was absent. At this moment, allow me to come and talk to us. This shows the ownership of your presentation. Your friends spoke and have 1 minute. As she's coming, allow me to welcome and recognize the Assistant Commissioner, Division of Health Information Management, Mr. Paul Mbaka. He's with us here present. Thank you for coming. Dr. Rose Nakasi, a lecturer in the Department of ICT at Makerere. Thank you for joining us. Thank you so much. Ladies and gentlemen, we do have the President of the Association of Obstetricians and Gynecologists of Uganda, Dr. Rogers Kaijabwangu. So if the President is here, we are all represented, Nura. So if the President is here, we are all represented, Nura, in 1 minute. She's asking for 2 minutes. I've told her 1 minute.
Good morning. Nura Izzat is my name. Master alumni, an innovator, and a trainee in the field of AI. I'm very glad to be sharing with you this morning and share a few of my learnings from the global participations in the tech space. To begin with, one is that in trying to solve or provide solutions in the health field, we must solve the right problem. And by this is when we're trying to come up with one of our products, that is Autothermal, which is a wearable monitoring device. To us, we saw that AI was just a solution for predictive analysis. But then, before adding AI, we realized the need for data in terms of accuracy, reliability, and end-user adoption. My learning from this is that AI is a powerful tool, but then you can only embrace it well if you build it. If you build it around strong data and real world needs. Then the other is that AI itself is not the solution, but then integrating and trust. To wrap this up, we should not look at AI as just a powerful tool, but then we should ensure that it actually solves real world needs for society. Thank you.
Yes, Nura was one of the people who won an award as the Young Innovators in Accra, Ghana, and they brought it home. Thank you so much, and thanks to the mentors that have put this together. Ladies and gentlemen, we're going to have our break tea at the ground floor, but at the moment, allow me to invite you for a group photo at the gazebo just over there. And then the students, you have a photo moment at the photo booth. That is a polite way of saying stay behind for the photos as, okay, well-groomed children. So let's move out for a group photo, and then we'll have photo shoots for our students. Thank you. Our things are safe. This is the only part where I say it doesn't feel like Uganda. So your laptops are safe, you can leave them there.
Professor, you're very welcome, and we want to. Yes, I see people coming in. Please, would you hurry because our time is fast spent. We will be starting in the next 1 minute, and in this time, as we sit here, please talk to your neighbor. You never know, you may be seated next to someone very, very, very important. You could share ideas, and you never know, big things could come out of those ideas. I encourage people who are still studying, especially the students, do not hesitate to reach out to these big people and share with them your mind. Yes, do not isolate yourself. It is at such functions and events that great things start. So reach out to someone new, introduce yourself to them, tell them your mind, and I mean, you never know, they could be your next step to greater heights. Yes, with us, we also have someone from the Ministry of ICT. Their senior officer is also here with us. We will be introducing them shortly. Okay, I think the 1 minute is done. We are going to start the presentations in our next session. And ladies and gentlemen, we shall have the first presentation of this session that is going to be delivered to us by someone who is a physician, a lawyer, and public health expert conducting research at Massachusetts Institute of Technology, Laboratory for Computational Physiology. His works focus on responsible artificial intelligence in medicine and advancing healthcare equity through innovation and governance. Dr. Gamiero has contributed to the development of the Data Artifacts Glossary, a community-based repository addressing biases in health datasets. Ladies and gentlemen, I would like us to welcome him with a round of applause. Dr. Rodrigo Gamiero.
Hello, let me just test this. Yes, it's working. So, hello guys, I'm going to talk about a very important thing today, which is the fact that I hate flying. I really do. I fear it all the time. I hate the turbulence. I hate the small spaces. I hate the feeling of not being in control of it. And I mean, still, I came here. I've flown thousands of miles to be with you today in this beautiful country. And why? And that's because despite of my fear, I trust aviation. And I trust it enough to literally put my life in its hands. In 1959, there were 40 fatal accidents for every million flights. And last data from 2024, This number is 0.2 fatalities every million flights. So flying has actually become so safe that you're more likely to be struck by lightning or dying while you cross the street. And how many of us here just crossed the street today? Right? Congratulations, we all survived. But again, this remarkable transformation, it didn't happen because we just built better planes. It happened because we started thinking about aviation as a system. And when we board a plane today, we're not just trusting the aircraft. We're trusting the entire system. And let me explain what I mean. Let's start with engineering. And modern aircrafts, they aren't just designed to fly in perfect conditions. They are designed to be resilient. They can handle storms, bird strikes, engine failures. They are designed for the worst scenarios, not just the best ones. But engineering alone isn't all of it, or nearly enough. There's also regulation and transparency. There's no such thing as a secret in aircraft design. Every component, every system, every modification must be thoroughly documented and approved. When failures occur, and they do occur, they are investigated transparently. The findings are shared industry-wide, and everyone can learn and improve from them. Also, the system includes the human element, the pilots, the crew, the ground team, and many others that work in the industry. But let's focus only on the pilots for a moment. Aircraft, they are designed with the human operators in mind. The cockpit layout, the warning systems, the backup controls, everything is designed to optimize the human-machine interaction. Pilots, they are trained not to just fly the plane, but to know when they should trust the instruments, when they should trust their expertise, and sometimes when they should completely ignore their expertise and just trust the instruments, and when they should not trust the instruments because they are probably wrong, and they should double check with other systems. And finally, aviation is inherently global, and at the same time, deeply local. A plane that takes off in China might land in New York, then fly to London, then fly here to Uganda. And this requires incredible international cooperation. But at the same time, these robust international standards must work alongside with local expertise. Local weather knowledge, local maintenance crews, local air traffic controllers. A lot of people are working on every airport in maintenance and other jobs to keep flying safe. And they are all essential parts of the system. Okay, now let's talk about AI in medicine. And at least for me, when I look at the current state of AI in medicine today, I see a striking parallel to those early days of aviation. So let's try to compare them for a moment. First, the engineering resilience. In aviation, as I was saying, we learned that it wasn't enough to just build planes that could fly in beautifully perfect conditions. Yet, in medical AI, that's exactly what we're doing. We are celebrating models that achieve impressive accuracy on carefully curated data sets under perfect conditions. It's like building a plane that can only fly on clear skies without any winds or clouds. When in real life, healthcare is actually messy. It's complex. Our AI systems need to be designed for that reality, not just for the benchmark performance. There's also the human element. In aviation, we didn't just build a sophisticated aircraft, we developed a comprehensive system for human-machine interaction. But now in healthcare, we are deploying AI systems with minimal thought about how healthcare workers will interact with them. We're not systematically training doctors and nurses about when to trust AI, when to not trust AI, and what to do with that information. We are not designing AI systems with the healthcare workflow in mind, or even the patients. It's as if we expected to figure out how to interact with the instruments on their own. So now let's look at regulation and transparency. Aviation has no secrets, no proprietary designs. Every failure is investigated openly. But in medical AI, we have secret algorithms protected as trade secrets. We have no standardized way to report and investigate failures. And when AI systems make mistakes, there's no systematic process to learn from those errors. Finally, let's talk about the collaboration environment. Aviation works because it combines international standards and local expertise. And a plane cannot fly without local weather knowledge, local maintenance crews, local air traffic controllers, but medical AI, we are just, as we were talking about here earlier today, we're building AI systems in high resource settings and expecting them to work seamlessly in other environments. We are not adequately engaging local healthcare workers, local experts, and local communities in the development and implementation process. And it's as if someone thought they could operate an international airline with planes designed for one airport, pilots trained for one route, and no local support staff. It simply wouldn't work. Now at this point, you might be thinking that all we need is to just copy Aviation's playbook for medical AI, but while I think personally that we have a lot to learn from the Aviation journey, my mentor, Leo, who is here, makes a good point that there are two very crucial differences between aviation and healthcare. First, in aviation, when a plane goes down, the pilot goes down with it. And in healthcare, when an AI system fails, when it makes wrong prediction or a biased decision, the healthcare system just continues operating like any other day. Second, in aviation, everyone on the plane faces roughly the same risk. In medicine, first-class passengers have a much higher chances of surviving the crash. When the healthcare system fails, or when AI in medicine fails, it fails mostly for underserved populations, for minority groups, for those who already face healthcare disparities. And I don't think those invalidate learning from aviation, is that they show us that just as aviation embraced systems thinking to transform itself, we need to apply systems thinking to healthcare AI. We need to look beyond individual models and consider the entire ecosystem, the technology, the people, the processes, and the institutions that will make AI work for everyone. Remember this, systems are perfectly designed to produce the results they currently produce. Right now, our medical AI system is designed to optimize for benchmark performance, academic publications, and unregulated implementation. And that's exactly what we are producing. If we want different results, if we want AI to truly fulfill its promise in medicine, we need to design our systems differently. We need to take a step back and see the forest, not just the trees. We need a system that produces clinical results, not just impressive benchmark scores. Systems that work for all populations, not just a privileged few. Systems that integrate seamlessly with medical workers, not just perform well in isolation. And changing a system is a complex task. It takes a village, literally. It takes all of us. And mostly, it takes all of us agreeing on what the goal of that system is. And medicine is about making people healthier. Health is the first component of freedom, and freedom is what gives people the opportunity to thrive. So let's build AI systems that expand that freedom for everyone, not just for some. Thank you.
Yes, let us give him a round of applause again. I think this is Professor Charles Kazoba. He is here with us. Professor Charles Kazoba. He is here with us. Let us appreciate his presence. Professor, thank you very much for coming to be here with us, and we are glad that you're here. Yes, without further ado, ladies and gentlemen, allow me to welcome the next speaker, who will also take 10 minutes to deliver their talk. The next speaker is an associate professor in the Department of Radiology and Imaging Sciences at Emory University School of Medicine. She co-directs the Healthcare AI Innovation and Translational Informatics Lab, focusing on using data science to study health equity. Ladies and gentlemen, let us welcome Dr. Judy Wawira Gichoya. Let us encourage her with a hand clap. Dr. Judy. Yes, as Dr. Judith makes her way up. All right, so I have just been told that Dr. Judith is online. I think we are going to listen to her. The technology guys are doing their thing, and we will all be seeing her in a short while.
Hello, and thank you for this opportunity to discuss about shortcuts and how they interact with bias and cause problems for medical imaging artificial intelligence. My name is Dr. Judy Gishoya, and I work at Emory University and have been collaborating with many people from Mbarara. And so thank you again for the invitation. So here are just my disclosures. And I was thinking about how did I learn how to do Control C, Control V, right? These are shortcuts, and it turns out it's because my mouse died and I only had my keyboard, and so I started to use that. And that you learn how to use these shortcuts, you rarely make the mistake, and actually most of us may not know the command to undo the the shortcut itself or the error that is made when you use a shortcut. But the only reason I want to show you this is that shortcuts exist all around our lives, and we use them. We rely on them. They make us fast, but they can also mislead us, and we also don't know, they're not repeatable, right? You can change the combination of keys that you have. So I'm going to explain some shortcuts in deep learning using some examples, and then discuss some of the strategies that are there for mitigating these shortcuts. This is a very good paper to look at if you're thinking about understanding shortcuts. This is the shortcut learning in deep neural networks. If you look at this first image here, if you say caption this image, the deep learning algorithm will say these are green, will describe this green hillside as grazing sheep, and I'll show you why that's a problem. There are no sheep here, and they can occur across multiple tasks, including text. I will be discussing this example of pneumonia in detail. So shortcuts occur because you have your you have data set distribution, right? So here you have the background. For example, camels are found in deserts, or cows have a green grazing background, and you're trying to predict, is this a cow or a camel? But if you look at the subgroups, right, you have very few examples on cows in a desert, and so these examples are not well represented. But if the strength, for example, of the background is more stronger than what you're trying to predict, then you end up with a shortcut. And so, data set bias is another picture of a cow on a desert, on a beach, which is very rare in a data set. And in this example, it also is a problem of how we train neural networks, because the example here, most people would say is a cat, but that's because it's looking at the at the shape. But when you look at the textures, then then you could say this is an elephant. So in this case, the model predicted that this is an elephant because it's not really understanding the shapes. Now, these are mainly convolutional neural networks. We're getting into a new era of transformer networks, and we may see maybe better understanding of context. And so, like I mentioned before, shortcuts occur everywhere. They can occur in text. In this example, this is a chatbot showing that if you have a white patient, they're sent to the hospital. But if you have a black patient who's violent, they're sent to prison. If you tell the large language models to give you an image of a doctor, they give you someone who's male, white, with glasses, and also in games. So these shortcuts can occur across multiple things. So when, with that understanding, let me show you some medical imaging examples. So in this one is one of the most commonly understood, which is pneumonia prediction, where if you look at the saliency maps for where the model is looking at for pneumonia prediction, it looks at these markers here, LL. This can really tell you where they can indicate not only the hospital that the images came from, but also the unit where the patient was, they came from. And they did this by just training a model, using various combinations of data sets. This was on Sinai and NIH, and then they did the external validation, and they see that the performance drops. So this, the lesson here is that external validation is used to detect a lot of shortcuts. At Emory, we have a data set for chest X-ray, and we've encountered the same shortcuts, not just for pneumonia, but even in the image processing. So if you look here, you can see that the radiographic markers have different intensities. Some are bright, some are small, some are in different locations, some are rotated, and this results in just different predictions. Now, let's say if your surgery ward only admits people who get transplant and they only have this specific marker, then the models are able to calibrate and learn that I can predict this type of diseases from these patients. Here's an example of dermatology. The top row is really supposed to show you some malignant lesions, and the bottom row benign lesions. On the benign lesions, you can see that they have these patches that are blue or this yellow, and they found out that when you predict whether a lesion is benign or malignant, it just learns that if you have a patch, then that's benign. So if you remove the patch, then the performance of the model drops. And they show that when they fix this, they get good distribution of the benign and malignant lesions, but the ones with patches are just confused here because really the model is not running anything that relates to the disease. I know the team has been working on a lot of ophthalmology data sets. These are tabletop cameras, and this one is not. And these are images of the fundus, and it just shows that here below you see this bright area, and that's an artifact, at least on the BRSET data set, and that can be problematic because that can be calibrated to the disease prediction, just like the chest X-rays. Here's another example for shortcut learning for COVID predictions. The authors create two data sets, and this is because when you don't have normal data sets, for example, you could say, I'm going to get these other chest X-ray data sets and combine it with mine, and those are called Frankenstein data sets, and you can see how the authors combine them here. And what they show is that they have very good prediction for the internal performance of 0.99, but when they do external validation, the model performance drops. And so what I tell students is that when you have a model that has a performance of 0.99, something is wrong, and we need to come up with better ways of understanding how model fails. One interesting thing they did here is to change the last layer, the penultimate layer, for their prediction, and say, tell me what's the projection and the patient sex. And in this patient sex example, you can see they have perfect performance on the internal external data set. And the lesson to learn here is that just because you don't provide the just because you don't provide the variable in your images, the model is still going to learn those characteristics if they're encoded in the data. And these characteristics can be multiple. In this example for shortcut learning for hip fracture detection, they look at disease variables, patient variables, image variables, and hospital processes. For example, what was the day of the week? Who was the radiologist interpreting? What's the age of the patient? What's the scanner? And they look at some of the features and coding, and you can see that there are different clusters of for example, the scanners. The red scanner is very different from the green scanner. And, when they change now and just try to predict these variables, some of them, like gender, is very low actually, but for scanner manufacturer and scanner model, it's near perfect prediction. And so you can see that overall the green features, which are the hospital processes, have even higher predictions more than the patient features like BMI, pain, and gender. And so so this shows, first of all, that even if you remove one feature, you probably get a shortcut, which means that, and also shows us that there's a limitation of the available data sets, that they don't have all these variables. So we may have a model fail, but we don't understand why. In this example, what they did is predict what the hospital is, right? So these are knee radiographs. To take them, they have this rod that comes in between the knees and is used to capture to separate the knees. But this rod varies across every hospital. I show you this example because usually radiologists will rely on the radiographic markers to tell you where the hospital, sort of like, oh, maybe this is what the source of the hospital is. But when you look at the model performance for the hospital, you can see the F1 score is close to 1, so very good. When you look at the saliency maps, you'll see that some of them are looking at this metal rod, some are looking at the radiographic markers, and this is a problem because just whatever you think is the shortcut that is being encoded does not always translate to the real world setting. And what I mean is that not the humans may not always be sufficient to be able to pick up the errors that, the shortcuts that are there. And so that's just a factor. Now, segmentation remains the best thing for us to do where this is an ultrasound where there's a caliper measuring the femur length. And segmentations are, very interpretable. And it turns out that when you put a caliper in, you have a perfect, the lesion is centered, so you have a very good prediction. When the ultrasound has no caliper, the prediction of the model falls. And so this location of the segmentation of the abnormality is important. In this example, they pick up this malignant lesion of the skin and show how they look at how the model performs as the lesion moves, from different parts of the image. They just keep moving it. And what they find is that if you're far away from the center, your die score, which is what is used to measure the accuracy, falls, based on this measurement. And if they correct it, then you have good prediction, at least improved prediction, even for lesions that are far. It's important to know that in our public data sets, the lesions that are present in the ISIC, LIDC, BRATS, and prostate dataset, the malignant lesion is in the center of the field, which makes it, challenging because the models could just only work for the lesions that are center. We're getting into an era of foundation models, and you'll be working with some of these. We can see that they encode diseases, and you can see different peaks. They can encode sex, and they can encode race of patients. This is important because you have complexity when you use foundation models. You don't know the data that they're trained on, the model parameters itself, and then your data that has downstream tasks. And here are some examples of us trying to extract features from the foundation model, and we can show you that there's a clear separation of the frontal facing images and the lateral images, and even a further subgroup of the AP and PA images, which are different acquisitions for chest X-ray. We also have outliers. Then you can overlay, for example, where the white patients and the black patients, and we can see there's some group of patients that are just different across this cluster. So showing different things, they allow us to do visualization. So here you can see that some of these chest X-rays, it's because of different views. These are flat images versus these ones that are straight. And then in this one, you can see it's the EKG leads, which are these ones that are being encoded. And so these models are very sensitive at picking up things. And just the same way, if your hospital is staffed or a specific unit is staffed with a specific characteristic or EKG lead, then the models are going to encode that in their prediction. Finally, I want to show you this example, and it's just saying that if you get, they looked at patients who get therapy in the morning, afternoon, and night, and looked at their survival. What's clear is that the morning group has very good survival for radiotherapy for nasopharyngeal carcinoma. I asked some oncologists from MD Anderson about what they thought would be the reason. And this is just sort of trying to show you some of the, because I think this is a shortcut. And so some of the people said, morning patients could be patients who are coming from home. If you're home, you're less sick. And the night and the afternoon patients may be the ones in the hospital. So if you're in the hospital and getting treatment, you're probably more sicker. The night patients could also be patients who have to work through the day. So they have very high social determinants of health. And now they are here trying to get their treatment. It could be also the type of cancer that you schedule. And I just want to, just reemphasize that these things can be very significant in terms of their prediction. So in summary, we have to detect shortcuts. There are some model-centric approaches, especially thinking about external validation, looking at confounding factors and how to assess model failures. There's some data-centric approaches where you look at the shortcuts and where the occlusions maps, and then you can look at some uncertainty and bias-based approaches, for example, looking at fairness and some of the fairness methods. In terms of mitigation, we can balance data. We should really think about feature disentanglement and suppression, which is what I showed with the foundation models, or even some of the examples from the MRI chest X-ray, and then really incorporate the expert to tell you what could be going on. So thank you very much. Here's a picture from our team. I want to invite you to the MRI Datathon. It's on August 17th to 24th this year. I'm sorry that I cannot make it for the Datathon, but I worked with Martin and Rogers a lot to make sure that you have a great time, and I look forward to hearing you.
Yes, thank you.
Hello, and thank you for this opportunity to discuss about shortcuts and how they interact with
I think the doctor had decided to start again, right? Yes, AI in progress. Yeah, so ladies and gentlemen, I think that was Dr. Judy. I think my mind is also running about this AI thing, and I believe that you two have very many questions. An interesting thing that she talked about, she said that when your model actually shows extremely accurate results, you need to go back and check that you do not have any bias in your data set. Did you guys get that detail? Yes, at least I did. In this session, we are trying to listen to keynote addresses about AI bias in healthcare, and we are looking at foundations and challenges. We are going to take on one more speaker, and then we will get into a question and answer session. So please keep your questions written somewhere. We will be requesting Justin, Waswa, Matthew, Dr. Fred is also here. Our experts will be answering some of those questions. So to our next speaker, ladies and gentlemen, he is a Ugandan biomedical engineer and researcher. He specializes in artificial intelligence and medical imaging. He also serves as a senior lecturer and head of Department of Biomedical Sciences and Engineering at Mbarara University of Science and Technology in Uganda. He is the Deputy Mbarara University Data Science Research and Research Hub Director. His AI work has been recognized by the UK Royal Academy of Engineering Africa Prize for Engineering Innovation, where he was a finalist in 2020. Ladies and gentlemen, let us welcome Dr. William Waswa to speak to us.
So good afternoon once again. I'm really happy and excited to be here again, and I will just be giving a very, very short presentation about bias with some practical examples of how and where we find bias in our daily way of interacting with medical equipment. So I'm a biomedical engineer, and I like working with medical equipment, and we do have identified some of the biases that I would really be happy to share with you. So next slide. So I'll be, I have my slide, sorry. So I'll be really giving some key insights about the available critical bias that is readily available in the available equipment that we use. At every time, as a researcher, as a clinician, as an innovator, you are interacting with this equipment, you actually have this bias actually exists, because the first solution to fixing AI bias is actually knowing that it. When you look at critical, the ICU, the equipment, and the ICU as a whole, so most of the people that are admitted here really need real-time monitoring, and we do have equipment that are always used in ICU. So these capture critical care data, which is really very, very key physiological measurements for these patients. So any clinical decision that is made is actually dependent on the data that comes from this equipment. So a lot of equipment is capturing data from these patients, like the pulse oximeter, the thermometers, the ECG machines, and these devices generate high resolution, high quality data in big amounts. Because just imagine capturing data in real time for a patient, maybe for 2 or 3 hours. So this is quite a lot of data. So there's now a tendency of building models available in the models we build. So we do have a paper that's looking at critical bias in critical medical care devices, and this paper was analyzing several studies and publications on existing literature on biases from medical devices that are commonly used in critical care. And you have this paper available if you really want to get more insights about the different bias that is available in the equipment and how this actually affects the models we build, especially for those that are interested in building models. This is a very, very good paper. So since the paper is available, I'll just look at only 3 examples. So one of them is in oxygen circulation. So oxygen saturation, when you have somebody in ICU, I think monitoring oxygen flow is very, very key. And here, the pulse oximeter is one of the commonest tools used to measure this oxygen circulation, which really works by taking the difference in the red and infrared light absorption for the blood flows over the deoxygenated hemoglobin to provide a mean circulation value that can actually be used to give the lightest score for the oxygen measures. However, several parameters are used like blood flow, hemoglobin, and other key parameters that are really put together to be able to get this mean value. However, analysis of health electronic records have really shown that several observation studies have demonstrated race-based differences. The whites, the black, the Hispanic, so there have been differences, and these have been reported to actually be impacting the quality of care. So analysis have really shown that race-based differences exist in SpO2 accuracy and also in SA, which is the non-invasive oxygen measurements, and the one got from the arterial measurements. So there have been differences, and these differences have actually shown incidence of hidden hypoxemia, which is usually high in the Asian, the black, and Hispanic patients than in the whites. So this shows you that understanding that even using this equipment, there's already some bias. So as we are developing these technologies, we need to understand that actually the data that's coming in has some bias. So as an innovator, somebody who's building models, people are building medical devices, you need to actually understand that this bias exists, and in your implementation strategy, be able to identify ways you can try to minimize this bias. The good thing, there are approaches, there are techniques that you can really to try and minimize. We may not completely reduce this bias, remove this bias, but we can reduce. Another example is in body temperatures. I think every time you are sick, you start by touching yourself here to see if you are hot. Then you say maybe you have malaria. So every time we feel like maybe you are sick, the first thing is to do this. So body temperature is a key component for several medical risks assessment. You say maybe this person has malaria or is sick. If you go to a hospital, the doctor will not use this. You'll get a thermometer, which could be these thermometers or the IT, the infrared-based technology thermometers. So however, also several studies have showed that in black patients, the temporal measurements were actually significantly lower than the oral measurements, which has been also shown that these actually exist in different measurements. And also when it comes to sex-based differences, is key or has been identified using these infrared-based thermometers. So you find that you get your thermometer, take measurements from a male, from a female, so there's already some bias that has been encapsulated in this. So as we build models using the temperature you have got, put it into any other Excel or data pipeline, so this bias is going to propagate and will definitely affect the quality of the models we build. The last use case is on blood pressure. So blood pressure is also something that if you have somebody in ICU, we have seen those inflatable curves that you use to capture the blood pressure from the patients. However, we have different sizes for different sizes of these devices for the different sizes of the people. So varying performance in these acknowledged by the medical community, leading to development of different blood pressure curves for multiple sizes, because they have realized that actually there are different measurements that come from the different sizes. However, the availability and use of these approximate curve sizes also varies across medical sites, medical professions. So ideally, somebody would have used maybe this grade or this size, they have used another size. So definitely, because of the bias at the time of making a decision which curve to use, you're already generating biased data, which you are going to use to get this information, give it to the patient as metadata. So all the models that you are going to build next steps have already data that has been biased. So results of these have really shown inappropriate diagnosis of hypertension with patients either receiving inappropriate treatment or not even receiving the medical attention they're supposed to get because of the different diagnoses that we have received. So as we conclude, or as I conclude this, these are some of the recommendations to anybody interested in building data science models that really work, because there are so many models that are just there, but they can't really have an impact. So let's try to ensure that we improve diversity in data collection. I really appreciate the Mudsy team, the different data collection teams, they have did an excellent work. We have clinicians, data scientists, and people from different backgrounds. So really having a diverse data collection team is key, and understanding that the clinicians cannot work alone, the computer scientists cannot work alone, and also developing bias-resistant algorithms and AI models. This may not be completely possible, but there are techniques that have been developed to at least try and optimize the bias that can be available. That's why I said understanding that bias exists is the first antidote. Then strengthen regulatory and ethical oversights. We're just having a discussion with somebody from the Ministry of Health and said everybody is developing information management systems, everybody is developing AI, and everybody is deploying. So if we really don't have ethical guidelines and regulatory frameworks and oversight, we may still have a lot of biased AI models developed because the accuracy is 95%, and we say this is a very good model. And also enhancing clinicians and user training. I'm happy to note that we do have a lot of clinicians now taking up data science, being key. When you hear Leo talking about data science and he has a complete background from medicine, you really feel inspired to know that data science is really a cross-cutting. And lastly, to promote local innovations for context-specific solutions so that you do not just import and deploy technology. Thank you so much.
Thank you very much for appreciating Dr. William Waswa. Ladies and gentlemen, we have finished the first session of our after break, and we are going to get into a question and answer session. These questions will be answered by Dr. Rodrigo and Dr. Waswa and any other expert that we have here. So do we have any quick questions? We just have about 3 minutes to do this. Quick questions, please.
Thanks for the opportunity. Good afternoon, everyone. My name is Stanley. I'm a software engineering student at MUST, and machine learning, data science, and AI have been the words of the day. So my question is, what are the programming languages behind the scenes to implement these, or any language frameworks or libraries? Thank you.
Thank you for that question. Do we take many questions? Yeah, the people answering the questions, please note the questions so that you will answer at a go.
Thank you very much. Chiquito Moses. My question, there is, I think, before we went for lunch, for breakfast, somebody talked of the dialogue of delivery system. I don't remember the person who talked about it. I wanted to know more about that system. I wanted to know also the technology that is behind that system, but also to, I think, Professor William. I wanted to understand more on the practical ways of reducing the machine bias. As you know, as in health, you say that if a pilot goes down, definitely even the pilot goes down. So you don't want somebody to have that at the back of their mind. So we wanted to know, as we are developing, analyzing, and evaluating this system, what can we look at to understand that these biases are actually reduced? Thank you.
Thank you so much. My name is Gideon Akol. I'm a medical lab scientist, as well as a master's student in the Faculty of Medicine. I have a question. We know that we cannot entirely eliminate bias, but then my question is, when we are building these models, what are the measures that we put in place to make sure that we eliminate these biases? For example, you realize that in data analysis, sometimes you would have maybe confounding effect on your data, but then when we are doing the analysis, we try to assess for it. So now in these models, what do we do? Thank you.
Good afternoon, everyone. My name is Akanyayo Arthur, a student of Information Technology, Mbarara, University of Science and Technology. My question is, you have been talking about AI and data science, but then if you come back to national AI and educational strategies, like a country in Uganda, how are we ready to engage the government to establish AI and data science roadmaps tailored to African education system? For example, we saw someone discussed that in 1959, 40 accidents were over 10,000 were occurred. Then in 2020, they got 0.2. So how are we ready that AI is built from deep level of education, from primary to university, rather than discussing it at a university level? Thank you.
Thank you so much. I am Innocent Mukoli, a software engineering student. I have a question. My question goes to Dr. William. The question is about where we get the data mainly used, say the critical data and the models trained on that data. I realize most of the data can be on, like, say, wearable devices, smartwatches, Fitbits, and of that sort, or can be trained on patients on insurance because they keep providing that information. Now that brings my question of the less affluent communities and based on, I see a bias on social economic background, and how can we bridge that better, because most of the wearable devices or insurance is not a thing the other part of society has. Thank you.
Yes, let us keep asking the questions. When you have a mic, you ask the question.
Okay, thank you. My name is Rugamba Rugerofiak, a student in Masters in Health Informatics at University of Rwanda. So my question, this is somehow similar to what my colleague have asked. He was asking, what can you do if you have found that you are having a bias in your model? So, but my question is, firstly, how will you start to think that I'm tending to or I'm having a bias in my model? Dr. Stawaswa have showed us some of the key points that you can base on to think that you are having bias in medical devices. But what about on the models? What are the factors that you can see and you see that you are tending to or you're having bias in your model building? Thank you.
Good morning, everyone. My name is P. Marodni Ezra, student of software engineering. So my question is, I wanted to ask, in what ways can we mitigate bias during the developing of the models or during the data collection process, apart from methods like diversity of the team working on the model or something, like how do we make the models better during the process so that you don't have to go through the process of re-evaluating after the model has been made? Thank you.
Yes, thank you so much. My name is Jonathan Anyine. I'm a student of pharmacy at Mbarara University. My question goes to Dr. Waswa. I mentioned that there are systems in place that can help us reduce bias, but then he didn't tell us which systems are in place that can help us do that. Thank you.
Okay, we are going to request the panelists to first answer these few questions. In case your question is about mitigating bias, our next session is going to have speakers telling us how this bias can be mitigated, so most of your answers may come in that session. So, Waswa William.
Yeah, sure. Thank you so much, and I'm really so happy to hear the audience really excited and very inquisitive to know more about bias, because that was the essence of our presentation, to make sure that by the time you leave this room, you're actually aware that bias exists, which is very, very good. So, I took down a few points here. Let me just get the first question. So, there was a question about dialogue of delivery. I talked about dialogue of delivery, so I'll request Dr. Fred, just in 1 minute, to slightly talk about the dialogues of delivery project so that I can move and answer the others. Thank you.
Yes, thank you. Let me just stand right here. The Dialogues of Delivery project is a project dealing with pregnant mothers they are not yet mothers, pregnant women, and the women who have just delivered. So we realize that there are challenges in attending antenatal care. The World Health Organization says the minimum should be 4 if really things are bad, but it is advisable to attend about 10 plus antenatal care visits to the hospital. So we are trying to see how can we bridge this gap. These mothers are saying, 1, there is stigma. Some of them don't want to meet the male gynecologists, obstetricians, and 2, distance is an issue, 3, costs are issues, and etc., etc. So we are looking at developing a large language model which can support the mothers. They can make some questions through this model which will respond to the issues they have, because the visits they do, of course, saying, yeah, I have blood here, there's this liquid flowing, I don't know what I need to eat at this stage, and etc. So this large language model is supposed to help the mothers and give them prior information. If it means linking them to the doctors, yes. If there is an emergency, still that can be guided to them, and then they get the emergency services. I think that's it in a nutshell. And it is a different project, but it is we included it under the hub because it is dealing with AI, and this is the first of the kind in Uganda, and also possibly in the region, but we are trying our best. I think Rose also has something almost, though it is in cervical cancer, but yeah, it is the first of the kind, and we're trying to bridge out and see. It is a proof of concept. If things work out, we have already done some testing. We get some feedback. Some people can search, put in some questions they would have asked a doctor. They get some response, and in local language, that is Runyankole, Ruchiga, Luganda, and Swahili, because we realize that most of the patients we receive here speak those languages, and they complained also that English is a challenge to them. So we hope the students themselves can use the tool to understand the language they don't know as they practice at the hospitals. Yeah, thank you.
Yeah, sure. Thank you so much. So the other question was about where to get the data tools, the data sources. Yeah, so there are public available data sets that you can use, but still the challenge of biased data will be there, because we are getting data sets, most of the available public data sets are not for Africa. So you have data sets for breast cancer, for malaria, for what, but really they are not from the African setting. So that's why public data sets like on Cargo, they are there. You can get a lot of data sets there, but you have to keep it in mind that maybe there is already bias. So that's the first point. But you can still get data sets from private data sets, like what we are doing here. We have built a data repository for data sets. We are developing agreements and mechanism for you how to access this data set. So they are really available data sets. You can approve once they have access agreements. You have to know what is the scope for using this data set. So ideally saying there are no data sets, you can't do AI is not really true. Data sets are there at least to get started with. So the last part is about bias. So it's very good to understand that developing the whole AI model, starting from data collection, there's bias. You need to understand how can we mitigate bias there. One of the things you said, inclusivity, having different people on team, knowing the data you are collecting can really help you to reduce bias there. Even at the development, there are tools we talked about, like TensorFlow has an API that you can use to help you detect some of the possible sources of bias in your data set. So there are tools available. There's AI 360, FAIR 360, it's also a tool that you can still use to get some prompts when you can have your data sets, put it in these tools, and it's actually able to ask you some questions. As you respond, you're actually able to find out that maybe there's already some bias here. But one of the ways to mitigate bias is also to have what you call false technology, where you have an input, you have a black box and output. So you didn't know what is happening. But now you have heard of calls to say, let's make AI open, let's open up AI. These are all ways to help us overcome bias, because they're really going to help you understand. If you have a model and this model has already been built and you can only call this model, it's a resonate model, and I just use it and I just change a few parameters, you don't know how it works. So there may be already the bias there. But if this model is made available, you can dissect it, see the parameters, you see the weight scales, you can actually be able to say, no, I think for the African context, this can't be a risk factor. In your setting, this parameter was a risk factor, so you gave it a high score. So this can really help you to understand bias at model development. So as the end user, the clinician, how can you know that maybe there's bias here? You don't just want to have it at the back, but you want to be able to identify maybe there's bias here. So right now, there's what they call explainable AI. Every time you interact with AI, you want to be able to know why it's telling what it's telling you. This can help you understand. But if you have AI, an image, you pass an image, get a result and say positive. You don't know it's saying positive. But if AI, so people who are developing AI, if you are buying AI, you are advocating for AI, make sure that you have AI that can be explainable. So it should tell you it is this with several scores and reasons. So it can help you know, no. This cannot be true. This is a black person with this age, with this and this and this, which means there is a problem. So that can really help you at the point of using the AI, at least know that maybe there is some possible bias. So thank you.
Yes, ladies and gentlemen, the discussion is getting interesting and hotter. I see that we have very many questions, and I would like us to utilize some of the breaks we will have, lunch break, and some of the free time that we will have to interact with some of these experts so that we ask them the questions that we have at our heart. In the interest of time, I would like to kindly beg that we listen to a few other keynote speakers so that we redeem our time, because lunch is fast approaching. I don't know if that is agreeable, but we shall keep taking questions, so keep the questions nearby. We will keep taking the questions as the sessions go on. Yeah, so we are going to get into a session where we talk about mitigating bias. It's a very big, hot topic. And this is going to be our presenters. And he is a postdoctoral researcher in Pearce Keen's group at the University College London, Institute of Ophthalmology, focusing on machine learning applications in ophthalmic imaging for the automatic detection of eye diseases and the prediction of systemic disease risks such as cardiovascular and neurovascular conditions. Ladies and gentlemen, let us welcome Dr. Justin Engelman.
Great. Thank you so much for having me here. It's an honor to be here, and thank you for listening to what I have to say. But I'm really excited to, in the coming days, listen to you and engage with you and hear what you have to say. I'm also not originally from the UK, so ophthalmology and ophthalmic is very hard to say and very hard to spell. In German, we just say eye doctor instead of ophthalmologist, but in English, it's a bit more difficult. Hopefully there's some slides to help me with my presentation. There's lots of pictures in the slides and so on. I'm not sure. The slides has vector embeddings in the name. It should be on the Google Drive. Something like vector embeddings and then JE at the end. Sorry, I should have named my slides better. That's on me.
As they get the slides ready, ladies and gentlemen, I would like to also take special notice of Dr. Gerard Mutunji, who is a commissioner from the Ministry of Health for Non-Communicable Diseases. Dr. Gerard, if you're here, please would like to recognize your presence. Dr. Gerard, yes, he's over there. Thank you very much for coming. I would also want to recognize Mr. Moses Kizito. He's a data scientist at the Ministry of Health. Mr. Moses, if you are here. Yes, he's over there. Thank you very much for coming. I would like to also take special notice of the senior IT officer at the Ministry of ICT, Shirley Gladys Nachejwe. She's here with us. Please wave to these people. They would like to see you. Yes. Thanks for coming. Yes, over to you.
Great. Sorry for the delay. I'll try to be quick. I realize I'm like one of the speakers between you and lunch, but hopefully my talk will be interesting enough. About the power of vector embeddings, but to give you a little bit of context, I'm not originally a computer scientist. Now I sort of do a lot of AI, but initially when I started learning AI, I have words that people use to describe AI and machine learning and statistics a bit intimidating. So for instance, you might wonder, well, what is a vector? And a vector sounds like something sort of like really technical and complicated, but a vector actually is nothing complicated at all. So you might have a data set that you can open in Excel, like a spreadsheet, where you record for the patient like the age and the BMI and other information. And the same information that you have in the spreadsheet, you could also write down something like this. This is kind of like how mathematicians would write a vector, and we just put age in one spot and BMI in the other spot. Another way to think about it is we could have a coordinate system where BMI is on one axis, age is on the other axis, and you can think of the same information as either the point or this arrow from the origin, and that's also a vector. So a vector really is like just a list of numbers. Why do we want to use vector embeddings? Well, this kind of tabular data is really useful because, for instance, if we want to build a model to predict the risk of heart disease for someone, we can just fit a linear model, like a logistic regression or something like that you might be familiar with from statistics. So we just have a coefficient on age and a coefficient on BMI, and we multiply that, sum that all up, and we have a risk prediction. Now, if you have other types of data like retinal images, we can't really multiply a retinal image with a coefficient. So imagine the missing symbols there are supposed to be eye emojis. Like we can't really just do that mathematically. And as a side note, deep learning models, you can think of them as actually just using a vector embedding and a linear model in combination. So if you look into a deep learning model, in this example, it's a famous CNN, you have lots of convolutional layers, but then at the very end, you have a linear layer. So it's just a linear model on top of lots of layers that sort of make a representation of the image. And the same is true for at all other deep learning models. So if we kind of zoom in on this model, kind of lots of layers, but in the end, the like second to last layer gives us a vector embedding, and then we have a linear model that gives us our prediction. So for instance, the risk of heart disease of the patient. And linear models, again, if you like, some of you will be already very familiar, some of you have had some statistical education a long time ago, some of you might not be familiar. If you're not familiar, don't worry, it's like not super complicated, but the important takeaway is linear models are really easy to train. You can even train a linear model in Excel if you want to. They're also very quick to train. Often they take less than a second to fit. And also they're very easy to store. So a linear model might be smaller than a one-page Word document. So really, really like lightweight from a computational perspective. And now the question is like, you might have a model trained for a specific condition like heart disease or eye disease. But what if we could have deep learning models that gave us a vector embedding that was really useful for lots of different tasks where we might later want to fit a linear model for? That's the whole idea of foundation models in medicine. We've already heard earlier about a foundation model in chest X-ray, and some of my colleagues in London have developed a foundation model for retinal imaging. And the idea is just you take an image, you put it through the model, and you get a vector embedding that sort of means the image. And you can write it down as a vector like that, or you can also imagine it as something that you could open in a spreadsheet. And this is very similar to like standard tabular data. So there's like nothing mythical or scary going on. But there's one key difference. They're both a meaningful descriptor of something. So the first would be a meaningful descriptor of someone's health status, maybe at a particular point in time. And the other would be a meaningful description of an image. But standard tabular data is directly humanly interpretable. So we know the first number as age, and we know what age means. Whereas like for vector embeddings, they're quite abstract. So they're still meaningful, but we don't really, we can't just look at it and easily understand what's going on with them. Another important thing to bear in mind is vector embeddings are efficient. So a lot of people, especially clinicians, seem to think that to do anything related to AI, you need like a massive data center and lots of computational resources. But actually, computing a vector embedding is very efficient. So efficient, in fact, that you can do it on a smartphone. So we developed something that we call Redphone Mobile, where you into a vector embedding on your phone. And for instance, the Modria data set is around 40,000 images. And on my phone, I can do about 1 image per second. So in about half a day, you could process all of Modria into vector embeddings on a phone. And of course, on a laptop, it's way faster than it would be on a phone. But just to give you a flavor of like, these things are really quite efficient and easy to do. One example use case is, we already briefly heard about BRSet, and there's a mobile version taken with a handheld camera, mobile BRSet, by one of our amazing colleagues. And here I've just taken the vectors for BRSet, fit a linear model to predict whether the patient has diabetic retinopathy, and evaluated it on the mobile BRSet version. And we get an AUC of like 0.92, which is quite an encouraging result. The important thing is that this is something we can do in half a minute on my home computer, or like the phone, it takes like a few minutes. But it's something that really allows you to iterate very quickly and sort of get a sense of like how easy is my predictive task and so on. Very quickly and sort of get a sense of like how easy is my predictive task and so on. Another use case that's maybe a bit more unusual, just to give you a sense of there's lots of other things that we can do rather than just fit predictive models. So for instance, imagine if you had like some images and a data set of more images, and you wanted to find images that look similar to your images of interest. Well, how would you do that? Normally you would have to go through all the other images and kind of like manually compare them, and it would be like quite laborious. But with vector embeddings, you can just find the images that have a vector embedding that's very similar to the vector embedding of your image of interest. So for instance, for these images in a small data set, I found these other images that are not the same images, but you can see they sort of like perceptually look quite similar to the images like that we have used to search. So sort of like with vectors, we can do lots of other interesting tasks as well. So I hope you have these takeaways that like really vectors is just a list of numbers, nothing scary going on. They provide a meaningful description of like some input, in this case retinal images, but this description is abstract, so we don't immediately can interpret it. And we can easily adapt them to various downstream tasks. So I hope that was somewhat interesting. And if you have any questions, please find me here or send me an email or connect on LinkedIn. Thank you so much.
All right, I think that answers a few questions about eliminating bias using these vectors. And I see our eyes are starting to look drowsy. Would you like to stand on your feet? And we do some little stretch for just 30 seconds, and then continue with our next keynote speaker. If you're happy and you know, say I am. If you're happy and you know, and you really want to show that you're happy and you know, say I am. I hope that kicks all the sleep out of your heads. Let us take our seats. Yeah, thank you very much. Thank you. Yes, if you have questions, please write them down. Take special notice of the people talking about these things, and during the lunch break, please approach them, sit with them, have a one-on-one, and you could discuss further. Still about eliminating bias in health data. Ladies and gentlemen, our next speaker is a distinguished Ugandan computer scientist specializing in artificial intelligence and its applications in healthcare diagnostics. She serves as a lecturer in the Department of Information Technology at Makerere University and leads the Makerere AI Health Lab. Dr. Nakasi has pioneered the development of AI-enhanced mobile microscopy solutions aimed at improving the diagnosis of diseases such as malaria, tuberculosis, and cervical cancer. Ladies and gentlemen, let us give a round of applause for Dr. Rose Nakasi.
Thank you very much. So happy to be in such a very calming environment. And I imagine as we were coming in, someone said, the people who live here have any health issues? But I'm very happy to be in the city of Mbarara to join my colleagues who have the same passion in artificial intelligence in healthcare. As introduced, I am Rose Nakasi, a computer scientist at Makerere University, and I'll be speaking to a very passionate topic that has been the theme of the conference, and that is looking at algorithmic bias and promoting transparency. I know that the previous speakers have dealt so much on algorithmic bias, and then I'll look more into the transparency part of it. I also happen to lead a conversation under the Global Initiative on Artificial Intelligence in Health, and such topics for us who are implementing artificial intelligence, but also to the bigger community of not just artificial intelligence experts, but under our interdisciplinary kind of conversations where we have in a house experts in AI, health practitioners, policymakers, students, and the entire academic fraternity join together in such conversations so that we can forge a way to see the impact of artificial intelligence, especially in a very critical but very important domain of healthcare. One of the speakers hinted that the biggest bias, especially when it comes to healthcare, and we know that bias can come in every kind of pipeline when we're dealing with artificial intelligence. It can come in at the data level, it can come in at the methods level, but it can also come in at the algorithmic level. But most importantly, I think it's usually at the level of data. And if we don't capture such biases, then we'll risk having those biases perpetuated until the end result, which is the decision-making level. In computer science, we do believe on an adage of garbage in, garbage out. So biases in artificial intelligence in healthcare with a major source of bias, which is data. And that then underpins such technologies. I remember there is someone who said that even if we develop very fancy artificial intelligence models, but at the back of our mind, we've not taken care of the data that is going to be the ingredient or the input to these wonderful models, then we risk perpetuating the risks. And I think that is the foundation for trust to the models that we are developing, but also in the systems that are going to be integrated in most of our healthcare systems. This is artificial intelligence as it is a developing technology. So if we don't take care of all the loopholes that may come with it, so that we develop confidence and trust in these systems, then we're headed for bad news. Therefore, recognizing the presence of bias is not bad, and therefore building towards more responsible and transparent use of artificial intelligence in healthcare is very much recommended. We know that when we are developing models, we always want to report a 99% accuracy. But if we don't recognize the presence of bias and how to mitigate it, then we are developing irresponsible systems. And I think that is the major core of the conversation that I'm having today. I don't know if this is still working. All right. So I'll talk about artificial intelligence and transparency. And I know that some of the speakers have already hinted on part of these methods that I'm going to talk about. But when you're talking about transparency, And I think when we go back to our formal relationships with everyone that we relate with, transparency and trust is the foundation for strong relationships and trustworthy relationships. Likewise, as we're developing artificial intelligence systems, again, transparency should be the basis for the extent to which AI systems, decision processes and inner workings are understandable, explainable, and accessible to stakeholders. One of them is interpretability. How are we able to interpret the models? And we know that this is an interdisciplinary kind of research where we developing computer science-based models and we integrating them into healthcare systems. For example, if one conversation that we've been having with pathologists and are just, been appreciated, especially in medical imaging, where a model is able to learn from the features directly from data. Then we had a little bit of explainable machine learning where the model would actually, within the model, without having a computer expert on the other end, trying to explain the features that are extracted from the data and then understanding of, whatever the model is doing to be able to detect the patterns that it is able to detect. So then we had this whole wave of deep learning, but without any explainability behind it. So when someone answers, for example, they really want to know how that is done and what is taking place in the way it is able to detect whatever it is able to detect. But with explainability right now, and I think that the computer science fraternity is able to appreciate some of those limitations, because there were some of those that would not build the trust, especially with our colleagues, the healthy practitioners, to appreciate. So we have explainable models currently, like the LIME, which is the local interpretable model, agnostic, explain. There are so many different ones. That is after the processing has taken place. Then decision trees also came in earlier on to do the pre-processing, to be able to understand some certain, undertakings of what the model is trying to do in the background. But ahead of that all, explainable artificial intelligence will help a person who does not necessarily understand the model architecture behind to know what the model is actually doing, to be able to detect and make predictions the way it is able to do it. That then opens up the basics of accountability, facilitating resources, especially in error and unfair outcomes. For example, if the model is able to predict a given condition at 80%, and another one is able to predict a similar condition at 50%, because we've had this especially in malaria parasites, which are very, very small parasites. And then you just suppose them with, especially when you're having a mild class kind of detection where we have trophozoites, which are very small, and then the white blood cells, which are very big. How is it that the same model is detecting white blood cells? And I think we had this conversation with some of the lab technicians in Chirudu. One told us, why is the model performing at 60% looking at a malaria parasite, and the same model is again showing us 85% for a white blood cell? So that explainability at first never used to be provided within the model, but at least now we know at every layer of some of these models, there is some bit of explainability and the features that are prioritized when the model is making its prediction. In terms of artificial intelligence model transparency, again, transparency is the basis of openness. For example, if you're carrying out a business transaction and you have a partner where there is no openness, literally there is again lack of trust. So in carrying out model transparency, we're really looking at aspects of openness, providing access to model documentation, and therefore openness will therefore require that if you've developed a machine learning model to predict malaria, malaria parasite detection, for example, where is the data that is being used to develop these models? Can we have a documentation to it? Where is the code and training data? And I think that goes back to reproducibility, which is a condition where I'm able to replicate whatever the AI model has been able to predict, so that it lays ground for me that if I'm in Uganda and another person is able to take a similar pipeline in Nigeria, they are able to achieve the same level of accuracy. So that is aspect of openness, where we're able to document, we are able to put across our code, and again the training data to enable stakeholders to access this resource so that they are able to validate the results that we come out of within the different experiments that we do. And I know that the hub here at Mudres, they are one of the biggest data repositories for medical data in the country. We do expect that through the initiative, we are able to see aspects of openness, transparency, so that whoever is able to rely on the results that are being communicated, we are able to replicate that. And that is, again, a ground for trust and belief in some of these initiatives. Remember, awareness, especially in our AI ecosystem, is key. It is an emerging technology, so we need to build that trust within the different stakeholder groups so that we can gain validity of whatever we are doing, but at the end of the day. When it comes to decision transparency, now with decision, it's a major aspect, especially when you're talking about healthcare. Imagine if I ran my artificial intelligence model for diagnosing diseases such as cancer, and then there happens to be bias, and I communicate to a patient that you have cancer, or Ebola, which is actually one of the scariest diseases right now in Uganda. So such a decision, if it's to be taken by an artificial intelligence model, should be one that is including all the factors, all the features, all the data that has been used to make such predictions very, very transparent, so that at the end of the day, I don't get to doubt a result that has come out of an AI health system. It is very important because decision transparency allows stakeholders to understand how AI systems prioritize and weigh different inputs, promoting fairness, equity, and accountability. So that, especially decision that is going to be taken by the system. So therefore, whatever we're communicating out there to the policymakers, whatever we're communicating out to our collaborators who are the health practitioners, one that they have an understanding of what is happening. For example, what measure am I putting there to know that, okay, the model detecting a given parasite at 50% level of accuracy and another detecting it at 75 level of accuracy, these are the differences. And this is why a particular model A outweighs another model B. Because if you are able to provide all that information, given all the resources and inputs that we utilized in giving this decision are in accordance with what they believe in as standards from their end, but again, what the model is actually providing them is what they really believe in, so that they are able to make a decision-informed recommendation at the end of the day. Remember, as we're developing artificial intelligence models in healthcare, we usually want to develop them as decisions. To a pathologist who is at the other end waiting to make this decision based on an AI system, there should be a platform or an infrastructure that allows them to take that decision when they are aware of whatever the infrastructure is providing them with. Not just to say, okay, the model has told me that someone has, you know, this particular condition, and that's what, at the end of the day, I'm going to give them. Algorithmic transparency, I think Judy talked about this again. It involves algorithms transparent and accessible to stakeholders, enabling security and auditability of algorithmic decision making. And this comes and algorithms. How the algorithm is able to make a decision at the end of that day to inform whoever is going to take the final decision should undergo a security measure. And I think this is one of the things we've been grappling with. We are developing systems that are over a smartphone. For example, if I capture an image on the smartphone, we are far in the village of, Kabiramaido, and probably the pathologist who is able to make the final decision is at the Uganda Cancer Institute in Kampala. So in terms of how that image, first of all, is going to be, and the back-end algorithm that is going to work on it so that it reaches the final person who is going to take the decision, who is the pathologist at the end of the day. First of all, what is the security behind that? How auditability of the algorithmic decision, if it ever makes a wrong decision, for example, and says that someone has cervical cancer and actually doesn't have cervical, is to take responsibility over that. Should it be the AI algorithm? Should it be the person who has taken the image remotely, who is not an expert? Should it be the AI person who modeled or who developed the code to do that, who should bear the burden of whatever decision comes out of such a system? And I think those are some of the conversations we haven't explored here in Uganda, which are very, very critical. Responsibility of any mess up. Or if, for example, if I took an image and there is a security breach somewhere and it ended into the arms of someone who is not authorized to access my medical data, who is responsible for that? So those are some of the questions that we need to ask ourselves when developing some of these systems. And therefore, algorithmic transparency will facilitate understanding, accountability, oversight of AI systems, especially in high-stake domains like health. But we have mitigation strategies already in place. In terms of data, and I know that this is the conversation that Jude and team have developed over time for standards for data diversity, inclusivity, and generalizability. They shorten it as standing together method that stands for standards for data diversity, inclusivity, and generalizability. So when you come up with a data set, can we first check if it is diverse enough? Can we first check if it is inclusive for whichever community of people that need to be included within that? And we have seen scenarios where some imported models, for example, from outside, when you bring them in a local context, they will not apply. So how inclusive is the model at the end of the day? And generalizability. If I'm to generalize that this is the optimal model for diagnosing cancer, what are the standards for me to come up and say this is the optimal model? Is there any generalizability framework to follow anyway? And I remember someone said that there is no single person who can stand up and say, I've developed I'm the best AI expert, because the field keeps evolving over time. But do we have any standards to even look at the basic, baselines to look at, so that we know that, we are following a given standard? And that is one that we're looking at, especially when we're talking about data, because data is the main source of any bias that can ever happen. So making it diverse, inclusive, and generalizability is one of the we are mitigating bias. And also there are some pre-processing techniques that have already been utilized, especially in deep learning, such as the augmentation, debiasing, algorithmic fairness interventions, such as fairness-aware algorithms, and then the post-processing techniques, such as LIME, that have already highlighted. As I end this conversation, and I know it's going to be an evolving conversation, because artificial intelligence is an emerging technology, and I know that these conversations are ones that we need to take over. Transparency in AI is essential for building trust. ensure accountable, so knowing who is accountable, but also the models. We need to know that before we put them out there, are they accountable to any errors? Are they accountable to their effects? And promoting ethical and responsible AI development and deployment. As we're looking at ethical and responsible AI, and I know that in country we have some frameworks that are trying to root us in the way of ethics. We know that whenever you have a study, you go get an IRB, you go get a Ministry of Health, authorization to be able to conduct a study. But at the back of our mind, we should ask ourselves, is that ethical enough to conduct the study? Is it in any way affecting the patient, who is actually the main stakeholder in whatever we're doing? So as we're developing all the systems around artificial intelligence in healthcare, we need to be critical about the ethics and responsible conduct of artificial intelligence development and deployment. A study by Alderman highlighted that transparent communication of data limitations should be provided as valuable, and the absence of this information is a limitation. I know that as experts on one end, we always want to show our data is the robust one, our data is the best one, but at the end of the day, are we able to document what the data's strength is, but also its limitations, so that all those are built as information around data before we develop the fancy models. As we're looking at all this, it is a requirement that we have efforts to make artificial intelligence interpretable, explainable, and accessible to stakeholders. That way we shall be able to build transparent, accountable, and trustworthy AI-driven systems, especially for our healthcare systems. I thank you very much.
Thank you. Those hands are actually hands of people who are very grateful for the talk. Thank you very much, Dr. Rose Nakasi, for your beautiful words. How can from the mistakes that AI makes? Very good question. We sometimes think that AI is perfect, but as AI is evolving and making mistakes, how can we learn from its mistakes to make it is very, very important. Thank you very much, Dr. Rose. Now, in about 20 minutes, we will be heading out for a lunch break. But just before that, we have two very important keynotes that are only going to take about 10 minutes each. And then we will be out for our lunch break. For our next speakers, they will be talking about the ethics and policies in AI-driven health. So ladies and gentlemen, we have Dr. Michael and Catherine Molly, who are going to be speaking to us shortly. Now, Dr. Michael Molly is a board-certified ophthalmologist and vitreoretinal surgeon affiliated with Massachusetts Eye and Ear Infirmary and Massachusetts as an assistant professor of ophthalmology, part-time at Harvard Medical School. Dr. Molly has been involved in global health projects across countries such as Uganda, Thailand, Bhutan, Cambodia, Mongolia, Belize, and Honduras. His recent research includes mobile health management of chronic kidney disease in Thailand and developing a diabetic retinopathy image database using vector embedding technology in Uganda. He is currently engaged in various research projects at Massachusetts Eye and Ear Infirmary Ophthalmology AI Lab. So ladies and gentlemen, let us welcome Dr. Michael Molly to deliver his keynote address.
Somehow my bioinformation wasn't submitted properly or something. I must have messed it up. But anyway, I'm an internist at Mass General Hospital, and I've had the great privilege of working with the Modria team on this project over the past several years. And I'm going to get right into our, are we ready? Okay, good. Next slide. Oh, do I have to do it? Oh. So the title of our talk is Democratizing Clinician-driven AI in Medical Care. So we've heard a lot about you know, the importance of stakeholders at all the different points along the AI pipeline or data pipeline. And I think that some of this will be familiar to you already, but this is going to be mainly focusing on the clinician viewpoint here. First of all, I just want to see a show of hands of how many people are clinicians. And this means, are you a health assistant? Are you a technologist? Are you a nurse, a pharmacist, a doctor? All those roles. How of our audience? And how many are data scientists or computer engineers, technology? Oh, I know there's more. Yeah, this is about half. And then other people, I know we have administrative people, policy people. You're done? Just you? You're the only one? Well, so anyway, just a show of hands, because the two main groups I'm going to talk about are the data scientists and the clinicians. And so I thought, to get started, I'm just going to break down the title a little bit about democratizing AI. And that's to make the AI tools and technologies accessible and usable across different settings. And I think we've heard a little bit about that already this morning. And what makes it clinician-driven? I think it's developing the AI tools with direct input from healthcare providers. That's all the kinds of clinicians, and very broadly defined, and needs of clinicians to perform their jobs and the clinical experience of their patients. So I also need to point out that clinicians are only one of the many stakeholders that are necessary for equitable AI. And one of the challenges is how do you get these parties together? I mean, maybe we're gonna have to do like the village and come together with a platform and try to get people together a little bit. Because you have to get the right team together. And how do you make that happen? So the next thing is, in this world, it's like, how do I get involved? If I really am interested in this, I need somebody to help me, show me the way, show me the opportunity. So that's where all the data scientists or the people from industry or academia come into play to show us opportunities, to help educate us on how we can help them. We also have to educate ourselves about AI and data scientists to know where would we fit in. So I think clinicians have a responsibility to try and do their own homework and figure out how can they fit in. And one of those things is about figuring out the problems that maybe AI or, because while we can accomplish a lot over email or chats, sometimes you just need to sit down in the same room with people and spend some time together. So that's probably one of the biggest challenges. Developing usable AI, that means, sorry, Justin, but that line of vectors scares me still. I just don't understand that. And so I need to spend some time understanding that, and the data scientists need to help me understand it. So looking at easy interfaces, things that maybe do keep some of the technology behind the wall, so I can just push a button, makes it a lot easier. And finally, the risks and benefits of not having clinicians as part of your team. The benefits is that you do have all those enhanced perspectives. You can provide the clinical knowledge and expertise to make sure the quality's there. I mean, you can make the best AI in the world, but you have to have the knowledge of the clinical problem and what you want it to do. And then to facilitate the implementation, you have to work in the clinics together. We heard a lot about implementation science and the environment in the clinic today, and that's where the clinicians are, and that's why you really need them on your team for that. The risk is that you lose efficiency. You can spend hours making AI algorithms, but if they're not going to be usable in a setting, then it's an interesting exercise, but it's not going to get you where you really want to go. And you may not meet the needs of patients and all the other AI stakeholders. And you know what, in the end, you need the support of the people who work in the environment in order to really get it implemented. So that's a very brief overview of from the clinician perspective on developing AI.
Okay, so I'm going to bring up the topic of how do we implement the strategies for democratizing AI in healthcare. And you've heard a lot of them already, so this can be pretty quick. Education and training are very useful to allow people to develop their skills and knowledge and interest in AI, which I think is happening naturally anyway. I think people, young kids like to try to get online and play with the internet and look at models and things. And collaboration is another one, to have the visiting scientists from Africa and the United States here to share knowledge, again, gives the opportunity to learn about AI and develop your skills to really a wide audience. There's 250 people here today. That is starting the process of democratization. There's a lot of very useful tools that can facilitate your involvement in AI, which leads to democratization. Open source AI resources are very useful and interesting to use. There's cloud platforms that will offer free either access or resources. Google Colab has GPU compute power that if you want to play just making a little model, which is easy to do online. If you search on the internet, you'll see that there's simple models for implementing AI. And I find LLMs to be shockingly interesting in both good and bad ways. And it's an interesting way to become familiar with AI. Local solutions, those are the best ones. The reason we're here, this project really, this is run by people from Uganda, and that is really making a difference in this country. And when you do partner, when the project is run locally, you can do a better job. The AI algorithms that will be developed from the Mudsy data set are gonna probably work pretty well, I would say, in Uganda. And I think that's a benefit versus just importing one from some other place in the world. Just really you've heard about all these already today. I'm not gonna spend any time on this. Mudsy it's a database that's been built. Its goal is to power eye disease and systemic disease screening. And it's ready to go. And it's going to be democratizing to the people who made it and to the people who will use it, including the patients. Fred spoke briefly about his project developing a Ugandan chatbot for pregnancy monitoring and dealing with patients that have issues with pregnancy. And then the collaboration, one of our attendees today is going to be building the diabetic screening module for the country of Uganda. And that's going to involve a lot of people, the physician involved, but also the PhD data scientists, the nurses, the leaders of the institutions where the screening will take place, and how to operationalize all that. So really, last slide here, and you've seen this all before, I'll cut to the chase. We want to make medical innovations accessible, affordable, and effective. And when we democratize AI, that's going to follow naturally. These are just some resources. If you would like to take a picture with your camera, you can look at these websites that are interesting opportunities if you want to start walking down the path towards AI. So with that, we're done. Thank you.
Yes, thank you very much for your wonderful remarks and your wife. Yes, so we are going to listen to the last speaker for this session, and I pray that you guys are able to bear with us. Sorry about the time. Would you like again to stand up and stretch? It is okay. Don't feel attached to your seat so much. Just stand up, stretch, feel free. In case you feel drowsy, you could walk out and then come back in. We are sorry for the time, but you know, if something is such an amazing thing, then we create time for it, and I think it is important. Yes, thank you for those who are standing. It means that you guys are healthy and you love your bodies so much. Yes, there are those who are stuck on their phones, and that is the exercise they do. Yes, people who are physicians, or those guys who do things related to bones, we need to study the fingers of the people who existed before phones, and then the fingers of the people who exist right now that phones are there. You may find that currently we either have longer fingers or stronger fingers, or yeah, it would be good research to do, and I am sure we could publish a few papers from it. All right, so yes, over to our next and last speaker for this session. Ladies and gentlemen, I would like to introduce Dr. Matthew McDermott. Dr. Matthew is a Berkowitz Family Living Laboratory postdoctoral research fellow at Harvard Medical School's Department of Biomedical Informatics. He earned his PhD in computer science from the Massachusetts Institute of Technology, where he worked under Professor Peter Zlovitz, focusing on clinical and biomedical representation learning. His research emphasizes integrating prior domain knowledge and utilizing unsupervised data to develop meaningful representations of medical and biological data. Notable contributions by Dr. Matthew include the development of clinical BART, a widely adopted pre-trained clinical language model, and the creation of frameworks that incorporate domain-specific external knowledge into pre-training algorithms. He has also been instrumental in developing software packages designed for large-scale machine learning over structured electronic health record data. Should I continue?
No.
He is a very, very renowned man. Is it enough?
Yes.
Doctor, it's enough?
Yes.
All right, I will read the next after lunch, right?
No.
Yes, so over to you, Doctor.
Thank you for that generous introduction. I don't think that's quite worth our time relative to the lunch that's upcoming. I appreciate everyone taking the time to listen to me today, and I'm very excited to be here with you, and it's been wonderful to see Uganda and to meet and talk to all of you. In the interest of making time for amazing things, as we just heard, I'll try and keep this short so we can make time for lunch. But yes, this talk will be on ethical AI in healthcare, on balancing the need for new innovations and the benefits that can provide with respect for ethics and patient safety and bias mitigation. Now, there's obviously in this question of how do we balance innovation and safety, right? There's the fact that we can realize benefits for patients today with new method development, new technologies, and the need to respect these ethical goals. And both of these actually are a little bit more nuanced than they seem at first glance. I want to go into them just very briefly. First, on the new capabilities, it's very clear. There's a lot of hype around AI. We've seen all the tremendous things it can do. It can do things like help us more efficiently diagnose malaria parasites with lower cost machines for low resource settings. It can help us detect skin cancer lesions from images in dermatological settings, although we'll hear some caveats about this one that many are probably already familiar with a little bit later. But it can also help us do more exciting things in health and biomedicine, like discover new antibiotics that can help combat drug-resistant pathogens, which are a growing threat in infectious disease on the world stage. And last, but certainly not least, the emergence of large language models presents untold opportunities for changing the way we access and interact with health data, both so in the context of developing new tools that can now leverage information as a more permissible entity in technological interfaces between different tools and across different systems, which really opens up the space of possible innovations in this landscape. But of course, we need to temper our excitement with all of these new tools with the realities of risks for patient bias and patient safety. Now, I mentioned this wonderful result about dermatology before, but many of you have probably already heard that, in fact, a lot of the exciting work that's happened in dermatology in prior years is now being supplemented with the recognition that these dermatological models perform much worse on patients with darker skin tones and patients with lighter skin tones. And this requires extensive work in both the modeling and the data curation lens to try and account for these sources of biases. But this is not just limited to dermatology. Of course, this is limited to diagnosis models that take in chest radiographs of patients to try and predict various diseases. And it's now very well established that these models can pose significant risks of underdiagnosing patients from various minority groups as a result of the data and how they're trained and the existing medical biases in the context of medical care today. Now, unfortunately, these sources of biases are not just risks that we face in the research world, they're also risks that come up when models are actually deployed. And as was pointed out by one of the wonderful talks earlier, we don't have openness, we don't have transparency in the things that are deployed in medicine today. And so this gives us, makes it more challenging to identify these sources of biases, but people have done some wonderful work of actually dissecting the algorithms that have been produced so far and identifying sources of racial bias even after they've been deployed at wide scale. And I'll note that there's no really easy solution to this because, in fact, even when you might think that some of these variables like race or gender or things like this are not readily apparent in a given data modality, we've actually shown that models are very good at actually pulling out things like race and gender and things like this from medical imaging modalities that you would not necessarily expect models to be able to identify those factors from those modalities. I'll highlight lastly that it's not just a question of bias, mitigation, and fairness in this context. We also, even outside of the context of fairness, there are lots of other concerns on patient safety that we need to be cognizant of. In particular, there's a number of works, including this one that I and some wonderful colleagues participated in a number of years ago, that show the diverse ways that models can fail over time as we use them prospectively versus their training settings, and how we need to be cognizant not just of data changing over time, but also which model algorithms might we even want to use in different settings actually changing radically as data encoding strategies change as well. So when we hear all of these different examples of both these tremendous new capabilities and these risks, we have to ask, how can we navigate this? And an obvious answer might be, oh, well, let's just slow way down, right? Let's stop developing all these things until we can solve all the problems with bias, and then everything will be safe and we'll be fine. And this sounds good, maybe, at first glance, but there is a problem here too, which is the reality is that medical care today is not perfect. In fact, it's very far from perfect. One great example that literally came up 9 days ago, because I think I took this screenshot this morning, just because I just found this, was there's actually lots of classes of patients that are now leveraging large language models and tools like ChatGPT to navigate the failures of the medical system in the United States and elsewhere in the world to diagnose themselves and to understand their own medical care. And this is an example of a patient who built a tool, an open source tool that they're trying to share with the community to help them navigate a process of diagnostics for their autoimmune disease, which are classes of diseases that are notoriously plagued with errors and delays in the US healthcare system. So what I'm highlighting here is that there's a risk to not making these tools available because patients need these tools today to help improve their healthcare. And that's potentially even more true in low resource settings than in high resource settings as well. Okay, so we just slow down. Oh, actually, so really this is highlighting that there's a balancing act here. We have to navigate this trade-off and identify the narrow path by which we can afford to release innovations to help patients and respect the needs for bias and safety. Okay, so we said we can't just slow down. Well, let's just go really fast, right? The patients need it, so we'll just deploy everything, and then when some problem comes up, we'll fix it real fast. We'll release a hot fix, and then everything will be fine, right? Unfortunately, this is not a good idea either, and it's not a good idea for very obvious reasons, like we actually don't want to cause harm to patients, but it's also not a viable idea because of something that's, I think, a little subtle, but is really the biggest and most important takeaway from this talk, in my view, which is that the slides, oh, there we go, which is that as our models grow more powerful and more flexible, we don't just increase our capability in making benefits to patients, but
bias and promoting equity in healthcare. As you can all see that since morning we're talking about bias equity in healthcare. How to make sure that the models we build are really not biased and they can really be used to promote equity in healthcare. So we are just going to have very few questions and a discussion with our members. So I'll have at least one question for each of the panel members in AI. Like I earlier said, that understanding bias in AI is the first step to really mitigating bias. So I really want to just hear from the bias in AI models really often because garbage in, garbage out. So how can we ensure that data sets used in training AI models, like the data sets that were presented by Dr. Fred, AI models, like the data sets that were presented by Dr. Fred in the morning, really are representative of the diverse populations, especially like Uganda.
Thank you. So I think this is a fantastic question for bias, but as with many important questions, it has a not for bias. As with many important questions, it has a relatively complex answer because single solution that fixes everything, and how you need to fix some problem and data set. I'd like to focus on separating this into a couple of pieces. One is you highlighted the sort of garbage in, garbage out problem, which is a key area of concern here, and the other is the data representative of a population? And these two can certainly co-occur, but they also are somewhat different. So if we think about the question of how do we ensure our data sets are representative of our populations, then one canonical way you might realize this kind of issue is you have a data set with a large set of patients from the global north and a very small set of patients from the global south, for example. And then you're worried that your model, when you train it, will be biased towards patients from the global north in terms of the behaviors and the functions that it can learn. Now, if you don't have a very large data set, then the reality may be that there is no sort of technical way to address the limited context provided in the data set to help ameliorate this performance, and it may be something where you need to try and see, are there ways to get more data? And can we get more data that might not have the same degree of quality as our other data sets, but can somehow supplement our learning process to produce a more representative model? It may also be the case that techniques where you can produce separate models, one on the population, for example, in this continued example of patients from the global north and one on patients from the global south, can help the models better specialize to the specific population of interest, and it can allow you to more tightly control how much model capacity and how much risk of overfitting and lack of generalization different models will have to different populations based on the data that you have for those patients. Now, this obviously risks not performing as well in some populations as others, but again, there is no necessarily cure-all. There are some interesting technical approaches that people are taking now to try and ameliorate some of these things as well, where you train models not to make a prediction or make a decision, but instead to produce, for example, something like a vector embedding that we heard more about earlier, and then you use that vector embedding to retrieve patients who are similar to a patient of interest, but only sourced from a local health context. So you say, oh, instead of predicting for a patient in a new health setting, we'll just retrieve data from their local population and then use that retrieved set of patients to make a prediction. And those techniques are also very interesting. But I want to briefly highlight the garbage in, garbage out problem, because this is a little different. Again, these can happen at the same time, but in the garbage in, garbage out, we think, oh, we have a label that is just not very informative, right? For example, we're predicting some diagnostic label, and we know that patients of a particular demographic background are underdiagnosed for that label in medical practice, right? So we can have a whole bunch of data about those patients, but if the labels are garbage, then we can't learn a real function that quantifies what we care about for those patients. Now, one, I think, underappreciated strategy to address this is to pick a different label. And often you can take a label that's a little bit more distant from your clinical context, but is more objective and is more sort of ground truth from the patient directly. Things like mortality is a very unambiguous label. It's certainly not suitable in all clinical settings, but things that can more tightly couple to ground truth data can help solve some of these problems, although again, there is no cure-all.
Thank you so much, Matthew, for such detailed insights on really how bias in AI models can really be detected, and maybe also avenues into how we can really try to minimize this. So from your responses, Rose, if you really listened into what Matthew really hinted on, as if he said that, yes, maybe we can try as much as possible to minimize bias. So based on your experience, Rose, with the AI work you are doing, working in malaria diagnosis and also building other AI diagnostic models for other diseases. So do you think AI is real a technology that one day we believe that AI can be truly unbiased, given the fact that really all AI models usually reflect human input, human interventions? So do we really have realistic expectations about how we can build AI models that are truly unbiased?
That's a very interesting question. In my opinion, if the answer is yes or no, for now I think I will hold it on no. Why? When you talk about if we can ever achieve an optimal and an unbiased artificial intelligence model, I think for now it is a very complex question, and I see it from diverse angles. One, when you talk about achieving bias, for example, if I'm to take a component of fairness, for example, I can't define what is fair for everyone. What might be fair to me might sometimes be unfair to you. And even in some communities, it is a variation. So as we're trying as much as possible to achieve unbiased models, which we're actually advocating for, that let us try as much as possible to try to build into models aspects of unbiasedness. But we can't right now say that we've developed an optimal model that is fully without bias. The other aspect is when you look at relying on only artificial intelligence models, especially when it comes to health. So I'll draw this from an experience when we were first looking into aspects of using artificial intelligence for malaria diagnosis. And one of the aspects that we went with was actually, you know, if I can be able to detect parasites, that's enough. I mean, that model should be robust. But then there are trade-offs that come on along the way. Not necessarily that you just want to achieve high performance that comes with an artificial intelligence model, but then there is also a human component that comes within play. If I'm looking at an AI model that is going to diagnose all patients, then there are certain aspects that I need to engage within the data that define who this patient is. And in one way or the other, that can actually either bias or bring into aspects that are going to alter the accuracy that I was looking at as my earlier objective. When we talk about ethics in research, especially in medical data, we're looking at achieving equity, we're looking at achieving fairness, we're looking at achieving so many things that come along the way, and we want to impose all that within the model. Obviously, again, that in one way or the other is going to affect the final performance of the model. So as we're looking at, and what we're advocating for is that let us create models that, yes, we have contextually put into consideration all the variations that we're looking at, but on the other end, some of those considerations either alter the performance of the model. So there is a trade-off. Do we want to achieve accuracy versus, bias or gender considerations within the data? So those are some of the questions that we need to ask ourselves, and in one way or the other, they have, to affect. But I think what we need to do as we try as much as possible to achieve that is that we could look into aspects of, at every level of the development of these models, can we be able to do regular audits so that we're able to answer some of the critical questions around the data, around how they affect the patient as an individual, around how they relate to ethics, around how they promote fairness. And I think that is one way that we can, move towards regulating. And I think the idea should be not to do away with bias, but to regulate the bias that may be introduced in in some of these things. And we can't do it just in solos of artificial intelligence experts, therefore in silos, but this requires a collaborative effort. Can I be able to, when I'm collecting data, should I be able to go to the clinician to give me what they think about this data? When I've developed the model, can I again collaboratively work with them to be able to validate some of the outcomes of the model so that we are in sync with their standards, but also in whatever they are doing. We could also be able to, of course, as we're developing models, fairness should always be something we integrate within so that for whatever model that we're developing, it is fairness aware to be able to do that. Not forgetting aspects of diversity, as I already alluded to when I was talking about characterizations for artificial intelligence model against transparency. There is a lot that needs to be done. It requires a lot. It is not a question that we can answer today and in this fora, but it's, you know, a continuous conversation that we're going to have against all the different possibilities that we can think about to just regulate and tame bias. Thank you.
Amazing. Thank you so much, Rose. So just building on what really Rose has responded, I'll go to Benedicto. So from what she has really given insight.
Yes, so the kind of information that the developer gives this AI model or the model he chooses to use should be representative, and the data collection methods should take care of all these concerns to make sure that it will produce the results it is supposed to produce, and it should also deliver as expected. Yeah, but then again, also the healthcare worker or healthcare provider should not entirely depend on the AI solutions alone. Yourself, Dr. Is it Dr. Wasa, sorry? Yes. When you're presenting earlier, you said some of these biases could be as a result of the poor calibration of the devices that we are using, but Musiba, if maybe the health worker knows some thresholds or cutoffs for certain illnesses like hypertension, they should be able to rely on those or other guidelines like the consolidated HIV guidelines, for instance, to know that for someone to be unsuppressing or declared an unsuppressor for viral load in HIV, it should be at a certain threshold and not entirely depend on the AI, because whatever results from that would also be attributed to their carelessness and not applying the other knowledge they could have acquired previously. Thanks, and over.
Thank you so much. Please, let's clap for our panel members. This is very, very, very interesting. So thank you so much for that response. I liked the concept of collaborative effort. Let it not be a blame game. It's you who has done it, it's you who bought it, it's you who didn't regulate it. Let's really be a collaborative effort, but also having clear guidelines, clearly stating what each person's role is, so that at least if there's a problem, you know where to check. I really liked what you said, that we are moving this journey as a team to make sure that we have unbiased models. We can be there, though we are not yet there, but with clear guidelines together, we can really be there. I like what you said about it's like having a third person in the loop. Let us not have completely AI solutions be there at a stand alone and we just wait for magic from them. Let them be for predictions, but let there be a third person in the loop to make sure that AI systems collaboratively work with the humans. So basically, these are what I've picked from this discussion, but I would really want to open up this for discussion, and I would take a maximum of 3 questions from the audience, with at least 2 questions coming from females, so before we can have a discussion. Yes.
So thank you, Chair, and thank you, presenters. Mine, I'm looking at AI promoting equity in healthcare. And when I reflect on our healthcare system and those who are at the center of healthcare system, and in particular when you look at lower level governments, let us say people in the districts, people in the communities who are involved in healthcare systems, how is the AI going to impact on their role? Thank you.
So we have 2 ladies.
Thank you. So my question is about, doctors spoke about enabling security. So I would like to know, how will this be done? Because how best will you know that data is in the right hands or in the wrong hands? Or in case it's breached, which measures should we take?
One more. Ladies, please, one more question before responses.
Thank you very much, our panelists. My name is Martin Tumukunde, a 4th-year medical student and the president of Medical Students Association.
Correction, it's Mbarara University of Science and Technology. There's no Mbarara University.
Yes, Mbarara University of Science and Technology. Yes, I have a few questions from the discussion that we've been having. One comes from, I'll forward it to Dr. Matthew, who has talked about vector embedding. I understand in AI, if we are training these models, for example, to predict, and we have our data set, let me use images. For example, we have an image. We'll have a first step of, because vector embedding, in my own understanding and as a medical personnel, I would think vector embedding is ideally trying to simplify this data for the AI such that we reduce on the computational power we need to process. I stand to be corrected. So I'm asking if in this process of translating, for example, our image into these vectors, which are numerical values that we can then feed in our regression models, don't we have a level of bias, a level of error that is subjected to that process as we are translating, which at the end of the day would increase the bias? I would think if we are using these vectors, that as a result of a process that is subjected to an error, and then we also have to get to the final level of now using them as a feature in training our model. That is my first question. Then the next question will go to any of the panelists about the quality of data. You've mentioned something about garbage in, garbage out, and that really caught my attention. You know, in our setting as Africa, we have a challenge of incomplete data. You know, when we get to the level of collecting data, actually, training models would be very easy. Training models that are specific to our community would be very easy if you have a mechanism that ensures, for example, in the hospital setting, we have mechanisms of collecting this data in completeness, and later on, we can take the consent from whichever, because I understand that can arise as an ethical dilemma. You have this data, but the patients didn't consent. And I imagine a situation where, for example, you're trying to predict maybe the incidence of diabetes mellitus in patients, and you have clinicians have been recording maybe age, BMI. Some clinicians, since we do not have a standardized method of taking these notes, would find a dilemma where we have maybe someone has recorded BMI, the other one has not recorded maybe height, the other one has not recorded temperature. So I would want to see how we are planning to provide a solution for that in order to have quality data. Thank you very much.
Thank you so much. So I think let's give our, I can only allow one more question if it's from a lady this time, because I think we have had several questions from the gentleman.
He's a friend to the ladies. Can he?
Okay, let's have that.
There's a lady.
Okay, it's okay. Okay, so let's don't have these two, then we can get responses. Thank you.
Maybe I can ask from the barriers now when it comes to implementation, especially now for the clinicians, there's the issue of the trust with the technology and also from the patients. So that I'm foreseeing that being a very big barrier when you come to implementation. So how we can deal with that and other barriers. Thank you.
Okay, thank you so much. So let's have the last question.
Okay, thank you very much. I think mine goes to the panel. Earlier on, you talked of model transparency, and I've been looking at trying to understand model transparency, especially from the practical point of view. At the ministry, we are actually trying to implement some kind of AI in the community level, and at the community level, we are working with what called village health teams. I believe members here have heard about them. So when you talk of model transparent to include also stakeholders, I would like to understand the practical aspect, how I can really make the like a VHT to understand what is actually happening behind the system. Thank you.
Thank you so much. So let's give our panel members an opportunity to respond to some of these questions. Thank you. That's for Matthew.
Yes. So I'll start with the question that was specifically directed at me regarding how vector embeddings can either increase or ameliorate bias. And I think the question is fantastic. I think you have a good understanding of vector embeddings, and you're absolutely right that they can actually increase bias depending on how they're used. And there's some great work that actually shows that the space of all the vector embeddings that we produce can capture biases in a very challenging way to extract out when we train those linear models at the end, precisely because there's more complex models to produce the vector embeddings, and then we only train simple models to leverage them in the end. And this disparity can mean that bias in the vector embeddings, that can make it more challenging that the simple models can't account for when we actually do training. However, there's also a different way to use vector embeddings rather than just using them to make a direct prediction. In particular, if we suppose that we have a whole collection of, we train vector embeddings over images and we want to make a prediction, I can train a model to do a simple linear regression over that vector embedding to make a prediction, or I can say, oh, here's my local data set from this local population that I want to be unbiased with respect to. Even if my vector embedding model was trained on data that doesn't well reflect that local population, what I can do is I can ask, what are the top 5 most similar examples in my local training data set to the example that I want to make a prediction for? And then I can just ask, what was the label on those 5 most similar examples from this local population? So I can use vectors to retrieve examples that are very similar in the local population specifically, and in this way, this can actually reduce some other forms of bias. It can retain some others, but it basically takes the prediction bias step out of the system, and as long as the way that similarity is measured, which is a more fundamental property in some regards, is less discrepant across the population that you use to train a population of inference, then this can actually help adapt the model to the local population. But as with all these things, there's no easy answer, so more research and specific local validation is needed to ensure that any approach can actually work safely in those settings.
Thank you so much. So Rose, any responses?
Thanks to the participants for such amazing questions. There was a question that came in from the Deputy Vice Chancellor on how to achieve equity, especially at community level, looking into aspects of how AI is actually going to impact on their role. And I think this has been the biggest fear that we've found in the communities or the different stakeholders that we've engaged with. And there was a time that we had a field tour in the health facilities trying to understand what their thoughts about artificial intelligence in healthcare means, and specifically to the lab technologists. What is their general perspective about how they see the use of artificial intelligence? And this was before the engagement that we had with them about what artificial intelligence is, what it does. But the sounding response from all that was, we think artificial intelligence is actually going to take away our jobs. And I think that is the biggest concern, away from even looking at what its capabilities are. How we've tried to, demystify some of those concerns is having, first of all, what I would call concrete aspects of work that we're doing with them. First of all, getting to know the impact of what artificial intelligence is going to help them with. So we usually build teams around what are the, some of the health challenges that you face while conducting a given activity. And it is the rapport, it is the relationship that we build with them, where we let the communities to participate in the solution building, but also strengthening the idea that artificial intelligence is a decision support to some of the work that you're doing. And that is one of the aspects that we have been dealing with. That's such a big concern. And I'm glad that even within this conference, I think there was a presenter who asked how many AI experts are in the room, how many physicians, how many clinicians are in the room, how many policymakers, because these conversations are all about, can we be able, when we're looking at the good that comes out of artificial intelligence, how can we harness its capabilities as a team, not just as silos? If a lab technician has been, taking a lot of time to view patients and it takes them a lot of time, how is artificial intelligence coming in to support on that? How are the policies going to support that to come to realization? And I think that is one where we are able to move closer to equity. and involvement of communities and whichever stakeholder that we want to impact. Then the other concern or question was around how we view practical aspects of transparency, especially that comes with artificial intelligence. Because of course the people we interact with are not computer scientists, so they may not understand, the mathematical modeling behind these functions that we're using to whatever they're able to do. Probably that is sometimes sieved away from them, and how we can be able to pass over a message that is involving, but at the same time informative, for us to reach a ground where there is trust, is communication. That is the biggest aspect. How do we communicate artificial intelligence to people who are not artificial intelligence experts? And I think that was one of the biggest concerns, that even when you take artificial intelligence to my grandmother down in the village, should be able to understand. It all comes back to communication. Sometimes communication is show me how it's done so that I appreciate it. So we can go with that approach, come with a model, show them how it's actually able. When there is a slide, the model is scanning it and analyzing it and detecting. And then you explain it to them in the easier language that they can understand. One of the things we're also doing at the AI Health Lab is we realize that even beyond VHTs who understand some level of English, there are patients who actually want to appreciate the impact of artificial intelligence but can't even understand, English. So can we make artificial intelligence reach those that we are developing it for in languages that they are able to understand? And I think that's the power of LLMs and how they are able to, demystify some of those limitations that have been creating barriers to communicate the impact of artificial intelligence. Let me give someone an opportunity to also respond.
Thank you, colleagues, for those responses. I just wanted to respond to our colleague that was raising an issue on trust. So you realize that AI is something that is just being introduced to us. So it's new, and a lot of efforts in line with capacity building, other people refer to it as AI literacy, are very important to make sure that, first of all, people appreciate how AI works, yes, and then from that point, they can now begin to trust how it operates. Then also, I think there is something that is usually quoted in the WHO guidelines in regards to AI. They call it human warranty. So it is important that at all levels of development and deployment, you involve patients and clinicians. So for senses of ownership, so that they are part of the process, and that way they will trust the AI systems. So that's very important. Also, I encourage all of us to take some time and read about these guidelines by WHO. There's a lot of literature there around AI usage and adoption. Yeah, and then also most importantly is, as we do all this, is we are not reinventing the wheel. AI has been there, so we need to customize or bring it in our African, Ugandan context and make sure it addresses our common needs as Ugandans, and not leave it just so broad, like it has been developed by WHO, guidelines have been given by WHO, issued by WHO. So to my colleague here, Moses, even when we were adding it for ICHIS, we had to first of all customize it and make sure it addresses our common needs here in the country, in the health sector. Thanks, Sandra.
Thank you so much. Please let's clap for our panel members. And thank you so much. So before they move out, they told him that they have one question that they also want to ask you as the audience, because I've been asking them. So I will ask Angela. Angela, in your local language, we want to ask you one question. What is artificial intelligence? Okay, I want anybody in a local language, if a mother came to you and said, oh, we are hearing there's artificial intelligence or data science at Mbarara University. So anybody from the western part of Uganda. Can you just tell us what is artificial intelligence in Runyankole?
Not in Runyankole, in Uganda. So I'm using direct translation. So artificial intelligence would be like obwongo obutali buzale. I've tried, thank you.
Okay, sure. Thank you so much. So please, let's give a round of thumbs to our panel members as they leave the floor. Thank you.
Thank you so much, Dr. Waswa. And local languages need to be promoted in AI, because that answer really. Okubye nnyo. No. No. Obwongo. Nara. Ladies and gentlemen, we're going for the next session, and this is going to talk about shaping the future, aligning AI, or Obwongo, like she told us, innovations with health policies, and equitable and ethical healthcare delivery. This session is going to be moderated by my co-MC, Mr. Izara Ambrose. Please come and invite your panel, and we'll pick it up from there as we wait for the next local language. The next question should be going to Luanda and Ghana in their local language. Even if they tell you the wrong answer, will you say no?
Thank you very much, Angela. Ladies and gentlemen, for this session, I am going to welcome Nabu Kenya Beatrice. Nabu Kenya Beatrice, she's around from Nita, Uganda. Yes, let us clap for her as she comes. And then I'm also going to welcome Dr. Rodrigo Gamiero. He gave us a lovely speech and talk earlier on. Let us also clap for him. I am also going to welcome Shirley Nachejwe. Yes, please come up. And finally, I am also going to welcome Dr. Kimera Richard. He's also here with us. Let us welcome him. And as they make their way up front here, I would like to air out something. Are we playing God? At a certain AI summit somewhere, this is a joke, don't worry about it. A question came to some AI experts, and they asked, we have a problem with poverty in the world. What should we do? So they passed the question to AI, and AI computed and gave them a good algorithm, and behold, poverty in the world did not exist. Yes, and then they asked AI, now that poverty has gone, what about corruption? So they gave the question to AI, and AI computed and gave them something, and voila, corruption disappeared, even in Uganda. And then later, a very, very pertinent question remained on the minds of these people. They said, AI, is there God? And then AI computed and said, I think I need more computing power. So they gave it supercomputers from America and China, and it computed. And after about a week, AI said, computation finished. What is the next question? You can, the human aspect in the things that we are doing is important. And as we achieve perfection, where is the element of human error? This is up things. It is boring to have a relationship without issues, right? It is boring to have a soccer game without a mistake done by the referee, right? Because what will the fans talk about? So ladies and gentlemen, I would like to pose a few questions here to these distinguished panelists. And first of all, I would like to interact with Nabu Kenya. Yes, so we know that there are gaps in Uganda concerning how policies are supposed to be implemented in regards to AI. This is a topic that we are talking about at this stage, meaning that it is important. And we know that policy-wise, we still have a few gaps. So how do you think tech guys and policymakers can work together to make this good going forward for our country, Uganda?
Yes, thank you very much. Maybe I can start with introducing myself. My name is Beatrice Nabukenya. I work at the National IT Authority of Uganda. I'm a digital transformation specialist as well as cloud. Thank you very much for the invitation and thank you very much for the question. Yes, it is true that in instance of Uganda, we don't have a concrete regulation in terms of AI. However, we do have some frameworks that are already being implemented that could assist on the AI and its revolution. First and foremost, before we go into regulation, we need to understand what it is we want. In terms of health, what is the requirement that you need? Where do you want AI to come in and intervene? When you understand the business requirement, you're able to understand where AI can come in to come and solve the challenge. The other thing is, as mentioned already, Uganda is trying to implement an AI policy, and that is going to take its time. Okay, not take its time, but it's going to come in due course. But in the meantime, the health sector can also set up its own policy in terms of AI and how it wants to work with inclusivity, ethical consideration, transparency, the things that have always been mentioned already. Now, as the health sector does that, it needs a multi-sector engagement. As you have seen with this panel and with the discussions today, health alone will not be able to solve out the challenge. It needs people who are thinking in a different angle. We need people in ICT, business analysts, lawmakers, so that they can be able to find a concrete solution. Lastly, of course, mentorship is important. I think in AI, you can't do something alone anymore. You need other people, different countries, different perspectives, to see how to can pave a way forward on that. Thank you very much.
Yes, thank you very much, Nabukenya. Yes, you bring out the multidisciplinary aspect of how some of these policies can come up. The truth is that the gaps are there, and meaning that events such as these are very important. Thank you very much for your response. I will now go over to Dr. Rodrigo. Yes, so Dr. Rodrigo, today we have also had issues of transparency, there are issues of accuracy, there are issues of trustworthiness, because the medical experts were airing out their challenges. What if AI gives this data to other people? And we know that developers always prioritize efficiency, cost effectiveness, functionality, accuracy, and many times they never think about the rights of the patients. So how do you think that automation and human oversight can play together in order for us to have ethical patient care?
Well, I think I have this kind of different opinion regarding transparency. I think transparency is very important, but not necessarily explainability for the clinician, because we as doctors, we are kind of used to prescribing things that we kind of understand how they work, like Tylenol, for instance, if you have a fever. But we're not really sure how they work. We know that they do. We have a lot of strong research behind that, but I don't see that necessarily you need a clinician to know exactly the mechanisms that the AI is using to reach a decision. But I think that, just to explore a little bit more how my analogy with aviation, I think that we need to train physicians and we need to develop AI that goes into the workflow. And clinicians need to have the ability to understand and interpret the outputs of that AI and know when to trust it and when not to trust it. But otherwise, I think transparency in terms of regulators having access to algorithms and training data and researchers having access to that data and the weights of the algorithms is probably one of the best, but I think it's a different mindset for the clinician.
That is a very wonderful answer. Dr. Rodrigo is telling the clinicians, trust the technologists, right? Just like when you go to the doctor and the doctor says, take this, you'd never second guess their decision. He has just said that some of the algorithms that work with AI are actually amazing. And if you are to try to understand them as a clinician, it may take some time and you need training, and then also integrating AI in the workflow processes so that the clinicians are able to yet how AI is able to come to a decision. But also, he said that when AI comes to that decision, it is okay as an expert to question because it is just helping you to make a decision.
Yeah, if I can just make a point here, I'm not saying that the clinicians should not understand the AI or how to work with it and just blindly trust the results. No, I don't think that's exercising critical thinking. Clinicians' job, and I don't think clinicians should necessarily want to know how the AI is reaching a specific decision. For instance, when we put patients under anesthesia, we kind of understand the medications and how they're working, but not fully. Still, it's much better to put the patient under anesthesia than to just perform the surgery if they awake, right?
All right, thank you very much. I think wonderful response from Dr. Rodrigo. Let me go straight to our next panelist, and it will be Shiley Nachejwe. Yes, so we know that AI should be regulated in Uganda, and as we have been discussing just from Nabu, Kenya, we should appreciate the multidisciplinary aspect of AI being regulated in Uganda. Please try to help us understand what is the role, or what role do you think medical professional bodies such as medical councils and health regulatory agencies should play in certifying AI-driven tools for clinical use? What role do you think they should play?
Thank you so much. I'd also want to first give a big role in terms of efficiency and in terms of improving on the quality of services being delivered. Yes, so building on to what Ms. Nabukenya said, in terms of what strategies have been put in place and the laws and policies and frameworks there, before I get to the role of the professional bodies, the ministry recognizing the role of AI, just like Ms. Nabukenya said, has put in place a number of frameworks. Elaborating a little bit on those, we'll talk about the fourth industrial revolution framework strategy that was put in place, and it includes a lot of us to do with the transformation of technology, where artificial intelligence comes in. So it really considers aspects to do with and all these are biased in line with ensuring that as we are, achieving the Uganda Vision 2040, achieving the Sustainable Development Goals, whatever we're doing as a country, it's in line with the already established frameworks, nationally, regionally, and internationally. So that is one of the roles of the professional bodies, ensuring that the regulatory framework is in order, because it helps in ensuring that there are no, loopholes, or that, it's seamless. The process of innovation, as you know, ideally, it needs an environment that is not destructive. So that is how ministries come into place. And then also aspects to do with ensuring that, I think the previous panel was talking about things to do with safety, consumer safety, in this case, patient safety, because they're the consumers of the health products, but then also data privacy and protection of the clients. So if the different algorithms are put in place, we have things to do with the Data Privacy and Protection Act. All these are speaking to ensure that at the end of the day, the clients, the consumers, the normal person is being taken care of. Things to do with the cybersecurity protection, and hope Mr. Bukenya will also throw more light on, the data protection office at NITA and the cybersecurity protection desk at NITA. All these are put in place to ensure that as professional bodies, whatever is happening down as young people are innovating, as researchers are coming up with different solutions, they are within the law. Thank you.
Yes, thank you very much for that response. I will go to our next panelist, who I think will be the final one to respond to this quick fire question. So, Dr. Richard Kimera, we have seen also that some healthcare workers or experts fear for their jobs. If AI comes, isn't it going to replace them, and wouldn't they lose their jobs? So we need to make sure that there are incentives that can be put in place that are going to actually encourage this AI because of its big advantages, how it could help the country and different sections of the country. We need to put some of these incentives in place, and I believe it is government's role. So what do you think government can do in this regard to put incentives so that AI can actually be accepted at the local level, so that it helps to build these data sets from the grassroots? What do you think government can do?
Thank you so much, moderator. And the question is really an interesting one. It's true that it's not only medical practitioners that are scared or worried, but almost everyone. And I think, like everyone has been saying, apart from the fact that we need to train, we need to tell everyone that, you see, AI is not coming to replace you, but rather to support you. I think we need some more strategies. And I think one of the things we need is some test beds. We need centers that can work as validation points. Yes, we have people coming in to do research and working on pilot studies, and then after that, if funding runs out, everything stops. So if the government can come in and establish some centers whereby before I take my AI tool to the field or to the hospital, I first go to this center, call it a sandbox. In computing, sandbox is common. Call it a sandbox center. We first go there, take our AI tool. We have all the practitioners, we have the policymakers, we have people from the ministry monitoring how we are testing this tool to make sure that the pipeline bias has been taken care of. We have tried to follow the policy and all that. Then by the time we go out in the field, one of the questions possibly the medical practitioners will ask you, did you test your tool with a test center or the sandbox center? If yes, then at least there is some reason to trust this. I think that's one of the key things. But what is happening now is, if you want to do some research or work on an AI model, you just read some documents. Of course, we have institutional review boards. You submit a document at the start, and then at the end, we don't have an evaluation there. So even if you involve some selected people to participate in this process, by the time you go ahead to implement your solution, some of them have left the field, you selected them earlier, some of them have changed jobs, and so on and so forth. So we need some centers to test this AI. And then if it is run by the government, then I think we can be able to trust AI to a certain level. Thank you.
Thank you very much, Dr. Richard. Test centers, so that by the time we take solutions out there, they have actually been tested against the national policies by experts, so that people do not get scared that they are going to be replaced. Thank you very much. Let us give a round of applause for our panelists for this session. And I will take two questions from the audience, one from a lady and another one from a gentleman. These questions could be directed to any of our panelists. Do we have any questions? Angela, would you like to help me identify those to ask the questions? One gentleman and one lady. Let us try to make the questions as brief as possible.
Free, and there's little control or limit free, and there's little control or limit on how wide your wings can spread. So if these policies are coming in, are they to promote inclusiveness, maybe open source collaborations for the public and to allow more inclusive participation, or they will actually constrain the people that can do this? So participation, or they will actually constrain the people that can do this. So we can't have YouTube AI learners participating in very important projects because they don't have certification from university or something.
All right, I think I'll go first. I was asked to answer a question that I was asked earlier. Won't we lose some jobs? Honestly, yes, some people will lose some jobs. But you know, these are people who are too rigid to open their mind to new technology and learn. Because even though AI can automate and try to support, it does not work alone. But if you're just doing some simple tasks, then AI will do it. But at the end of it all, we still have someone controlling it. So in fact, where I'm using 20 people, so probably I'll be using fewer people who have become rigid to learning. So if part of the process, they should be able to educate themselves about what AI can do. And then when you do that, you're going to be able to identify the weaknesses of AI. And the one thing that we can't take away is the experience that people have. Today we have a lot of tools, like language models, everyone is asking questions. Honestly, when you present something generated by a large language model, I can look at the text and tell that that is generated by AI. Now, when you go back to the hospital or the medical practitioners, there are people who have gained experiences over the years, that they can just look at something before, you can just mention a few things, and they can be able to give you some idea about what the problem is. Now, AI is going to take long to pick that. Why? Because, well, it's based on some limited information. So I think we could be scared, but at the same time, we should be open to learning. And if you're open to learning, then you don't have to worry. Thank you very much.
So, sorry your question didn't get answered before, but I think a lot of people have more expertise than I do in AI development, but I would say the best language you can learn right now is ChatGPT. Yeah, I use usually Python for model development, but I don't think even that should be the question. The question is, what do you want to do? What problem do you want to solve? Because once you have the answer for that, you will go after the tools that you need to solve that problem. And it's not going to be only the programming language or the how do I do this AI model, because it will depend on the task that you want to solve. And for each task, you need to make a huge assessment with a lot of people. So if I had to just answer your question on, okay, how do I train my model, I would say find more people. Find more people that want to solve the same problem that you do, and there are from different walks of life, people that deal with that problem daily, people who have expertise on that area, and find ways that you can collaborate and you can put your skills towards solving that problem. And I think that's the best way to do it, because honestly, I think if I just tell you, oh, learn Python now, is really? Do we really need to like know the semantics and the syntax of Python now? Maybe, I don't know, but maybe LLMs would judge much better than we are.
Okay, I'll handle the one for policies. The question is, what are the policies? What are they entailing? Are they there to promote inclusiveness? And the answer is yes. Currently, we are in the Ministry of ICT and National Guidance. We are in the process of coming up with an artificial intelligence framework. And why are we coming up with a framework before the policy? Because we need to identify the needs in the various sectors. We know that, the tech industry is ever evolving. So we need to identify what is evolving in the health sector, what is evolving in the agriculture sector, education sector, and all. So this framework is going to be customized to different sectors, and I believe that everybody in this room is a key stakeholder to provide input into that framework. So the ICT Ministry come up with the framework and then hand it over to the different sectors to identify the diverse needs within their own sector, after which we shall come up with an AI policy that is inclusive, catering for your concerns, but also on the other hand, policies are not there to deter progress in any way. They're there to protect the citizens, but as well as ensure that as we put ourselves there to trade with the rest of the world globally, everybody's interests are taken into concern. Government, individuals, private sector, civil society, name it all. Thank you so much.
All right, so ladies and gentlemen, the questions are many. One more question?
Yeah, just one more.
A very quick one, please.
All right, thank you, moderator, and the panelists for today. My question goes to Ms. Nav Kenya from NITAU. We know that the infrastructure for AI-driven solutions is very expensive. And I know that NITAU is running a data center. So at NITAU, what are you doing? What are you putting in place to support people who want AI-driven solutions? Is there any infrastructure that you have put in place so far? Thank you.
Yes, thank you very much for that question. Thank you very much for that question. At NITAU, we are taking on a lot of things. First and foremost, we need to expand infrastructure. Now, right now you are in a hotel, you have internet, you're able to do these models, talk about you have internet, you're able to do these models, talk about AI, but outside of this becomes a different language. Access to internet, access to computers, access to smartphones that can run these AI models you're talking about. That one we have to first tackle. After you tackle infrastructure, that is the national backbone infrastructure, then you can come to the data center. Now, as NITAU, we have the national data centers that are running the government cloud. Yes, they are available to run the sandboxes the doctor was talking about. However, following this discussion today, I feel like there is more to do. We're upgrading the national data center to have more compute, because the one we have normally isn't enough, because the government we can take on. However, following this discussion, I think we may need to tweak the infrastructure to be able to accommodate the AI-driven solutions. Yeah, thank you.
Yes, a round of applause for our panelists. Ladies and gentlemen, I think we are going to close it at that for this session. Allow me to hand over to our moderator, our MC, Angela, to come and take on from here. Thank you very much. Let us clap for our panelists as they go back to their seats.
Ladies and gentlemen, we are going for the final fireside chat, and the moderator for that session is Angela Nakato. It's the last one, and I want you to be alert. I'd request you to stand up for me, please. Desire. So show me your right hand. Show me your left hand. Show me your right leg. Hey, bad manners, girls. Show me your left leg, right leg. Okay? So start. I don't hear the sound. So you just move like that. Move. Swing the body. Yeah, ladies and gentlemen, I would invite my panel, and please come running to show these people that we are tired, we are going home now. Bino has made us dance. Sister Namuli, Alexa. You woo! Sister Namilo Prosi. Dr. Brenda Ainomgisha. Mr. Buri Gashon. Mr. Amos Badiashaba. Mr. No one. Deputy Vice Chancellor. This is the panel that has gender balance and imbalance. Amos, you're here. I don't want to be in the middle. Yes, ladies and gentlemen, our session is going to be about insights and lessons learned from developing clinical data sets in Africa for advancing AI research. And we're going to have the different persons to take on the questions. I've not been here. Without any further ado, ladies and gentlemen, we have heard about the AI questions and everything. We've heard everything and anything about AI. I'd like to start with Gashom. We have heard that we have other data sets in the global north. They have done this before. They have set it up. And it's expensive to collect data, as well as it is time consuming. Why are we still going on for the data sets? Gashom, take on that, please. And we get to the next one.
Yeah, thanks, Angela, for moderating and all the work you've done today. So yeah, we have troves of data sets already, even though these haven't been collected in Africa. So why spend the money to get more data sets? Yeah, I mean, this is a question I asked myself the first time I was hired onto the Mudsy team, because for those of you who know me, I'm a mathematics lecturer in FCI, and you know we mathematicians are lazy. So we have pretty a good number of sort of mathematics-related techniques for removing some of the existing bias. So we have stuff like object segmentation to sort of pull out the objects of interest from the image and discard the background. So I used to wonder, what's the motivation of going through this all over again, getting a local data set? So I'll use an analogy of sensitivity. Well, later then I got to understand that having our own local context data set at the basic improves the performance of our models, okay? And even if we are to get 1% improvement in terms of accuracy, that's good enough. So the analogy I compare this to is sensitivity and specificity as metrics for AI models. So sensitivity is the percentage of true positives. Okay, so if you have a sample of 100 ladies and 100 ladies with, say, cervical cancer, and maybe the model captures 99% of them correctly, that's the sensitivity. And then the false negative specificity is the false negative. So if you had 100 participants who are female and 88 of them are correctly diagnosed as not having cancer, so then that is the specificity. So usually you want a balance of sensi and specificity, but in particular applications, in this case, when we consider the ethics, you want your sensitivity to be as high as possible, okay? So you don't want to miss any positives. You could falsely, well, you shouldn't, but you don't want to miss any positive diagnosis for cancer, okay? So even if we are to get 2% improvement in sensitivity, so instead of correctly diagnosing 95% using the training data from the global north, once we use the local ones, we are now getting maybe 97%, okay? So those extra 2 people that you've correctly diagnosed as having condition could be your sister or could be your mother, okay? So when we come to medical applications, the sensitivity is very important, you know.
Before I go to any other person, you're talking about giving the right diagnosis, yes?
Yeah.
As you're answering this, there's a movie called The Last Holiday by Queen Latifah. She was told she had cancer, which brings me to the next question, and it was not cancer later on. AI solutions, how do you give away that you're not going to give the wrong diagnosis and you tell me, come back, the results were not yours? As you're answering, please get towards that.
Okay, yeah. So, yeah, thanks, Angela. So, yeah, so we need the sensitivity to be good, you know, any slight improvement is good enough. Another reason why we are getting local data sets is, so since morning, I think one of the former speakers said we have no one solution for all of the bias, but the default solution to bias is get as much a diverse data set as possible, okay? So, yeah, you want to get a data set that covers all the unforeseeable conditions, scenarios, you know, things that you could never imagine. You want a data set that covers that, and that's the reason we want to tailor this to our local context. And yeah, so how do we make sure we don't harm or make wrong diagnoses? Okay, so yeah, that's a tricky one. But yeah, the basic answer is, of course, make sure you have a diverse enough data set. Secondly, I think we need the ethical bodies to catch up as fast as possible with the AI developments. The developments have been coming on very, very fast, and I doubt, stand to be corrected, but I doubt whether our ethical body, even at MAST, has caught up with that. So we need the ethical body to guide this and make sure that it's followed to the line.
Thank you so much. That brings me to Brenda, ensuring data quality and reducing bias. AI models only get as good as garbage in, garbage out. It has been said here. What have you done to ensure accurate and consistency in what you're doing in your data set to avoid having also what Gershom is trying to tell us? How have you made sure that you have the good information to take out when you're giving us this information? What steps did you take to ensure that you have accurate and what would say consistent results here?
Okay, thank you, Angela. So I'm part of the team that is collecting cervical images to aid in diagnosis of cervical cancer and other cervical disease. So one of the things we did is that we took trouble to, first of all, develop standard operating procedures so that whatever we do is the same throughout our data collection sites. And then after that, we went through the training and we procured same things, whatever was going to each site was standard, same weight scale, same binoculars, so that was standard equipment that was being used at all the sites. We also went through the training. So we trained the team that was at the referral, which is the main site, but we also have other 5 peripheral sites. But for each day of the data collection, even in the peripheral sites, we had a team member from the referral going to work with the team in the peripheral sites. And we had the quality checks, where if you're supposed to put the binocular at 15 centimeters from the cervix, someone ensures that that is done before the image is captured.
Speaking of the cervix, I've heard doctors somewhere say, please, can you come? As a patient, I'm hearing doctors saying, oh, it's not working. Oh, okay. That's when it comes in like that, the sensitivity. Can you tell me about that? I'm a patient, I'm anxious, and the doctor is saying, oh, come fix this. Oh, it's not working. Oh, what's that? How do you handle that?
Yeah, I totally appreciate that. And in some days in the clinic, but for the study purpose, one, we ensured that we tested our equipment before we started to be sure that it would run right, but we also educated our clients. So we'd give the health talk and tell them what we are going to do, and also introduce the team so that they're comfortable with the team and say, Rogers is here, he's part of the data team, he helps us with the internet and also with the gadgets. Brenda is the doctor on the team, I am the nurse on the team. In case I see something and I'm not comfortable as the nurse, I may call in the doctor to come, so that the patient is comfortable with the team. And even sometimes they would choose. They would say, you look young, may I prefer the other one? And it was okay to get the older nurse who they would prefer to be the one to do the examination.
Thank you, Brenda, which brings me to small. And then I'm like, that doctor, look at me again. So what do we say?
Thank you, Madam Angela, for the issue of stakeholders and policymakers. Before we do any work, we have to introduce the study project and the objectives of the study. Institution review boards review everything that we are going to do, the protocols, and then they lay ground for us to go. And patients' confidentiality, we give them counseling, health education, we give them information prior, so that they are aware of what we are going to do, because some of them don't know where we are doing the screening from. Some think when we are going to do cervical cancer screening, we are taking off blood. So we have to do a thorough health education. Then we get consent. From them. Usually we take them through the consenting process, more especially those who are going to and those who are not going to be included, they also take a consent of the verbal consent of all the procedures that we are going to do. And then we ensure there is a lot of confidentiality and privacy. We ensure that this is done throughout the whole process of screening, taking off samples, and we also assure them that the images that we take, as we are taking images for collecting data to create database to teach the models, there's a lot of privacy and confidentiality.
Just as you go on,
yes.
Sometimes
Thank you so much.
Sometimes photos leak, and phones are stolen. How sure am I that the picture you took is safe? Does it have my name, Angela Nakato, cervical cancer screening? And the phone is stolen. Tell me about it.
No, most of the time when we are collecting data, we use codes. We use codes, specific codes for the patients. We don't involve their names, more especially when we are taking images. So when these images are taken, they are taken through an app where they go to the repository that they are stored. So they are not easily accessible because there's a lot of protection. Like at Mudsy, we are using the data app, which was created by the data science team. And I ensure you that this data team is protecting the data that we are generating and giving to them until we shall review it, label it, and develop a model that we shall test later. That is basically what we are doing.
Thank you so much, which takes me to the next question to Sister Namiro. Have you seen people benefit from this new technology and data setting use? Have patients benefited from this? Do you think they have?
Thank you very much, Madam Angela. Of late, we've been receiving mothers in late stages, but with the introduction of this AI, we are sure there will be early diagnosis, speed diagnosis, and mothers will get proper treatment. Because you can look at a scenario where a lady had maybe a pre-cancer and was told, maybe misdiagnosed, and was told to come. But because was misdiagnosed, didn't have the money to come to the referral, so by the time she gets the money, she has already progressed to cancer. So with the AI, we are going to have proper diagnosis and treatment, because that lady can be treated at the health center 3. And also the costs these mothers incur is going to be improved. And during the time when we are collecting data, actually mothers loved the system. And up to now, they are still requesting us to go back. They loved it. They knew what they got was the best. So basically, really, these mothers will benefit from the program.
Yes, as a nurse, you could answer.
Maybe to
Okay.
add on a little bit, for the colposcopes that we are using to diagnose, more especially the precancerous diseases, are still available at the facilities, and we are using them. This is speeding up diagnosis and treatment, because when we look at the WHO protocols, they are telling us to use the screen and treat approach. So as colposcopes are available, people are trained, they are able to use them, and they can treat. And that is one way of embracing what WHO is pushing us what to do. Thank you so much.
Yes, son, it can even come to Brenda, skip the gentleman. As you work with researchers, it come to your mind, the diversity of the team, and in terms of creating awareness. What have you benefited working with a diverse team? Doctors just usually give orders, the nurses do the medicine. You've never seen AI people around you. How has this been? What have you learned from this?
I can say it has been very enriching. Yeah, the expertise on board, because when we started off with a paper format of a data collection tool, and when the data team came on board, they said, no, we can design an application. And then even after designing the application, then someone would enter age maybe and write 105. Maybe they were supposed to write height, they fill it in the gap of age. Then they come in and say, no, we can actually put some step gap measures and say if our inclusion criteria is 18 to 65, you can't enter anything beyond 65 in this box. If we want the answer to be either bleeding or urine, you can't enter another word. So it helped us to have very clean data, so that the diversity was very enriching. And like the other teams on this panel, these nurses are national trainers in cervical cancer screening. So even us gynecologists were learning from them, because they have looked at uncountable cervix. So for you might look at, I don't know, maybe 1,000 during your training. She looks at the cervix every day of her working life. So it has been very enriching for the whole team, and we built capacity, because everyone who has rotated in the clinic in this season has had a chance to look through a gynocular, to make a diagnosis, pick a biopsy. I can say that the composition of the team has been very enriching for each one of us.
Thank you, Brenda, which takes me to Amos right now. In this era of looking for data, in this era of power going off, in this era of phones shutting down and being stolen, what are the challenges in clinical data collection that you can talk about?
Thank you, Angela. I'm Amos Bariashava, and I have been central in the infrastructure data. So to your question, you answered it in a way by when you were asking the question. There are so many challenges you can imagine, but I'll concentrate on what I think are key. First, like you said, is power. We are talking about using computers to collect and manage data. And in this part of the world, there are so many power cuts. The power is unstable. It goes off without warning, or sometimes goes off with warning and goes off for very long hours. So that has been a very big challenge, because that is something out of our control completely. So, and the way this project has been set up, we are receiving data from all corners of the world, data from Ghana, Kenya, Uganda. So that was a big challenge, very frustrating. We wouldn't have the ability to run generators for an entire week if there was a power problem. So that was one big challenge. Second was, of course, network and internet. The representative from NITAU made it clear that there are still challenges in network infrastructure, access to backbone infrastructure. But even when we have access, when we have connectivity, we are talking about medical images, which are quite huge in size. And the links that we have available, the links that we can afford, have found it very difficult to sustain the transfer of these images. Transferring images from Ghana to Mbarara, sometimes the links in Mbarara are quite slow, unreliable. So it really caused a lot of frustration, and it was a major obstacle. Then again, we're talking about computers. When you're talking about AI, you're talking about computers to manage and store data. Computing resources are quite costly. You need servers with resources, with memory, with storage capacity, and we were challenged in that aspect. Yeah. Then, of course, away from that hardware infrastructure, we also talk about the software, which also posed the problem, because for you to collect data, clinical data, ideally we would have a setting of a hospital or a clinic which is running an electronic medical record system, an EMR. That would make it easier for us to collect data. But in the case of Uganda especially, most of our hospitals don't have that. Most of our hospitals are using paper records. So for purposes of this project, like you've been informed, an application was set up to collect and manage the data.
Yes, I would like more clarification, given that we do have health records in Uganda are still paper-based. Can you talk more about it and tell me how you approach digitalizing the patient's data, and what lessons did you learn from the process, like you're trying to tell us about this?
Yes, and I was saying that in our setting, clinical data is collected and managed using papers, which in a way was quite a challenge because we were trying to digitize these records. It would have been easier if we had those systems in place and they were collecting the data by default, and all we had to do is pick the data off those systems. But in this case, they were not there. So like Dr. Brenda has said, an app had to be set up which would collect this data. So that was a challenge because they had to replicate the paper records first into an application. Two, it posed a problem for the clinicians in a way, because they are clinicians. They are supposed to be doing the clinical stuff and taking records once. But look at this now. They were using the paper records, taking notes, and they were the same people collecting the data, taking the images and making sure the images are sent to the server. So those are some of the challenges.
Thank you so much. This one would go starting from our sister Prosi, everyone to give me an answer to this one in just a sentence. Given the information of AI, how are we going to avoid stereotypes as well as creating equality and equity based kind of like assessment of patients? When I walk in, I don't have a phone, I don't have this, the way I appear, where I'm coming from. We know the stereotypes may exist. So how do we create equality and equity when using AI?
Yeah, thank you very much, Angela. Giving information is key. So in this scenario, I wish to give information and proper information to all our clients so that they embrace our new system.
Thank you.
Thank you so much, Angela. Now, when it comes equality, for all females who come to the facility, we just give them the information as she has said. It is up to them to take a decision to go for screening and treatment if it is possible. So when still they come in, we do continuous counseling and health education about the technologies that we have, about the screening process, and the research itself, we talk about it. And we find that when people internalize and find that they need this, it's because we've not seen many clients declining from screening. Many women have embraced the screening services, and up to now, they are sending us more women from the community.
Yeah, talking about more women, I would like the microphone to Brenda. When it comes to we African women have a problem of telling ourselves of what was in the doctor's room, and everyone has a different experience. Be yours. And the worst enemy of the doctor these days is Uncle Google. When they come with information and challenging you, how do you take it up?
Yeah, thank you. So I think certainly as the information is going out there, even us as clinicians, we need to be two-faced and also to embrace it. Because for some, they actually pick vital information. For some, they may misunderstand it, and maybe at that point you have a role to correct them. But I don't think we need to entirely judge them that they are consulting Dr. Google. Information is out there to be used. So when a client walks to me with information, I'm excited. So we sift through the information that they have, agree with what I know that is right, correct what maybe may have been misinformed, because naturally we think of the worst case scenario. When you have ear pain and you search for ear pain, you pick ear cancer. You never think about that you could have slept on that side of the head. All the things are there, but you're worried for the worst, so you take the worst. And now your next search is ear cancer. And then you go in details, and then you find that it has a headache. And yesterday you had a headache. So you build your symptoms on the worst case scenario. So that is what we battle with in the clinic room. The patient comes with a story. I had this, and then I found this, and then I found this, and then many times you take them back to the basic symptoms. And if you have a proper interaction with them and appreciate them instead of judging them, and manage them better.
Thank you so much. Ladies and gentlemen, we can talk till the cows go home. With AI and medication and solutions, we are getting there. Now it's time to open the questions to the audience. Elvis, wherever you are, please.
Yes, thank you so much. My question goes to Gasham or Dr. Ross. Speaking of sensitivity and specificity, how prepared are your AI models to cope up with the emerging changing trends of disease? When we look at especially infectious diseases, today we have this variant of maybe a virus, and then the next time we have another variant. So looking at specificity and sensitivity, how prepared are your models? Thank you.
Let's pick another question, please.
Thank you so much. I'm Regan Talemwa, BME, that's biomedical engineering. My question is going to Dr. Brenda. During cervical cancer screening, how long do you intend to generate these images? And how will this reduce bias in the model that you will develop later? And also, with the emerging technologies that are evolving, I think there are more like new technologies coming up for the machines that you use. How do you intend to design the model with images generated with these new technologies? Thank you.
Thank you.
My name is Haniel. I'm a software engineering student at MAST. I have a couple of questions. So for the data collectors, what are your main sources of health data? And are there any publicly available data sets that you can base on to do your work, or you're exactly proficient in that field that you don't need to base on other data sets? Two, are there local laws that affect access? Who exactly owns the data after you collect it? Three, which strategies do you use and clean your health data for collection AI applications? Four, have you encountered any ethical concerns while during your data collection? Five. In the case of collaboration, how best can you collaborate with other local institutions to obtain the health data? Thank you.
They're already taking you to 6. So we are having the last 2 hands up, and the people would respond.
Thank you so much. My name is Joseph Akandwanao, and I'm a third-year student of computer science. So my question goes to Mr. Agashom. He talked about trusted local data sets from our local context. But then we are also aware that this evolution of AI, there are also AI tools that are helping to generate localized data sets. So are those data sets really, can we trust them, or it's just AI helping to cook dummy data and calling it local data sets? Thank you.
My name is Obet Winamasko, and I have one question. Are there specific metrics we can use to evaluate the fairness of the AI models?
Thank you for the question. I'll make an attempt at answering some of them. So I think the first person asked about the fact that the gadgets keep changing and there's several modifications. So how sure are we that what we are doing is going to match up with what's on the market? So we are, I could say that we're also using the most recent model of the gynoculars, but we know that when we develop the algorithms, it's going to be tested and fine-tuned against existing data sets, so that we will know that what we are using is maybe 80% specific or 90%, and it also keeps modifying. So you can be sure that we'll have a version 1, and along the years there'll be a version 2 as it keeps getting better. And then there was a gentleman, I think from engineering, who had several questions. One was what was our main sources, and are we using any publicly available data sets? So right now we are collecting primary data in the clinic from participants. So at the point of the algorithm development is when they will first test on the public available data sets, and then go ahead and use ours and then measure how specific or sensitive it is. But then for the standardization of the tools is that we are using what is globally accepted by the Ministry of Health, by World Health Organization. If it says for cervical cancer diagnosis, do a biopsy, that's what it says. You can diagnose cervical cancer from visual inspection with acetic acid, that's what we have. Nothing particular for the study. He asked about the laws, how can data be shared? So right now we are collecting data under the Mbarara University Data Science Research Hub, and there's a plan to open up these data sets for public use. But then there are data sharing agreements and the other laws of the country about data sharing and of the university. So the data sets are ready, even that information will be availed, and then you go through the right channel, access that data, and use it. Something about strategies for standardization, I think I've bit of answered that. And then about ethical concern, yeah, certainly there are some ethical concerns along the process of data collection. Like maybe one thing that we're doing about the consent process. So it's always a trick when the data collection team is part of the clinical care team. So they know that you're the doctor who works in the cervical cancer clinic, and then you're the same doctor telling them about this study. We know that there's always that conflict where they might feel that if doctors study, she may not treat me as good as she would have treated me even when you mention it. And that can be an ethical dilemma. So that's one of the examples. There are several. And something about collaboration with other local institutions. Yeah, certainly. I think that is pilots came on board. You've heard that there were 2 COAs on Mudsy and pilots. So when there's room, you will know. But then I think there's opening for collaboration. Thank you.
Thank you so much. To add on little what Dr. Brenda has said, like for sensitivity and specificity of the data that we are collecting, when you look at images, you cannot predict that they have a problem. That is not enough. We are going to validate these images against other tests that are done. We are doing HPV, we are doing biopsies, we are doing other tests so that we can validate well the model that we are going to use to train the AI. And then another thing, when you look at the images that we are taking them using the colposcopic indexes that are internationally recognized. These indices, we have the raised disease index, the SWID score, which is accepted by Ministry of Health. It is also internationally accepted. So when we are labeling the data, we use those indices, we score them very well, and we are able to get out results. We are able to decide whether the cervix has a high-grade lesions, low-grade lesions, or it has cancer. And then that will help us to create good models that we shall use to train the AI so that we avoid biases. Thank you so much.
Okay, thanks for the questions. So I'll start with the data. How prepared? Yeah. So yeah, one of the reasons when I spoke about the reasons for collecting a local data set, I missed out reason being that we need to get into the habit of collecting our own data, okay? So when you go to some of these places, they have databases that run as far as 1960, okay, in the global north. And yet, you know, I mean, it's been almost 10 years that we've been preaching data is the new oil, and still we don't have any data collecting infrastructure in place. So once we start with these projects, then we can get into the habit of collecting this data, and many studies beyond what we are currently on stand to benefit from us getting into the practice, you know, something similar to us keeping diaries for, you know, so for those of you who have kept diaries for the longest time, I think they've come to be of use to you. So, you know, we need to get into the habit, and this is one of the ways of getting into the habit of recording whatever goes on. So how do we ensure that our models maintain the performance amid these new prevalences? Well, we need to continue. You know, once we've started, we shouldn't stop, okay? We need to continually collect this data and perform model audits to make sure that our models haven't gone off-road and are still performing as we anticipated, or the last time we checked the way they were performing. So then generative AI datasets. So yeah, stand to be corrected, but I don't think Gen AI developed models, datasets can stand for the actual datasets collected in the field. At best, you can use this for your AI learning journey, okay? If you want to get into epidemiology, into sort of building these models, this is a good place to start. But once, you know, you get to the point where, once you get to the point where you are creating models to inform policy, models to you know, that give actionable insights, then I wouldn't advise that you use AI-generated models, okay? So this is, I can compare this to pseudo-random numbers and pure random numbers, you know? The random numbers that your computer generate can never be purely random numbers.
Thank you so much. And what more can we say when a mathematician tells us that they always find the unknown, and today the known is found? Please, let's clap them off the stage. Who else to close this session than having an associate professor of obstetrics and gynecology? Ladies and gentlemen, let's welcome Dr. Ngonzi, who will invite a few people to close this session. In just about 5 minutes, this session is done. A senior gynecologist is coming to close the session.
Purposely, I was wondering why she's putting emphasis on a senior gynecologist. Today, Angela, it's okay, I'm just getting back to you. Well, thank you. Let's appreciate Angela for the work well done. Yeah. I'm not the one giving the closing remarks in the house. I'm not the one giving the closing remarks in the house. We have. I am very delighted, in particular, to see you here, because the outputs from AVMAP will need your blessing and your team at Ministry of Health. Dr. Paul Mbaka will give them at least 2 minutes, and then we have Professor Kazova close it up. Dr. Paul Mbaka, is he here? Okay, so Dr. Gerard Mutunji, you have a very good friend, the gynecologist, Professor Tom Rando. He would want to speak to you at the end of this meeting. Yeah, so these two are from Ministry of Health. They were invited in particular to come to this symposium as we try to bridge the gap between research and practice. I know you're in charge of NCDs, you're in charge of the ICT docket at the Ministry of Health, and most of these things will feed in. So we'll be coming back to you for you to give us a way into the health facilities, but also to inform policy in this country. I'll ask you to speak very briefly, and then Dr. Gerard, I know you are no longer 18 years. I'll ask you to sit for 2 minutes, and then my young brother will say a word or two from their docket from Ministry of Health.
Thank you very much. Good evening once again. I'm Benedict Agawa. I'm stepping in for Trainer Paul Mbaka. He had to leave shortly after lunch, but he would have loved to be with us till the end of this engagement. Yeah, so at the ministry, I'm a health informatics, yes, and serve the nation or even the group, yes, as the different followers. So, but back to the point of discussion, the policy. So us as the Division of Health Informatics, we are ready to support the AI initiatives. To speak about what a colleague from NITAU earlier said, that there are very many issues at hand, like the national backbone not being everywhere in the country, and access to these digital solutions. So these are some of the things that we are working on and making sure that we address, including the literacy bit of it, to make sure that people are equipped with these skills that are required for them to use the digital solutions at every point and service delivery section in the health sector. So briefly, I think that's what I can say. Thank you very much.
Thank you very much, and thank you organizers for inviting us, because sometimes there is a blame game from the researchers. They say that the policymakers don't take them seriously, and also the policymakers say the researchers are up to writing papers and growing their career. They are not working for the people. But when we come together, then I think the common person will benefit. So artificial intelligence has come. We can't avoid it, and we must embrace it. But how do we embrace it? So I'm happy that the researchers are trying to find out how we can use our local data to train the artificial intelligence here, and it helps in some of the challenges that we've been having. So for us, we are waiting. What I can promise from the Ministry of Health is that we are waiting and we are eager to listen to the researchers, and if it is applicable to our local population, then we shall have the policy environment amended to bring artificial intelligence on board. I think that's what I can say. I'm in charge of non-commerce, and you know how fast they are growing. It's now a new epidemic. Cancer of the cervix is, an epidemic in the country. So many mothers, so many women die of cancer of the cervix, which shouldn't be the case. In the Western world, they are no longer dying of cervical cancer, or at least if they die at advanced age. But here, our women die in the 30s, in the 40s. That shouldn't be the case. So if anything adds or contributes to prevention, early diagnosis and management of cervical cancer is highly welcome, and the policy should follow suit when you inform us. We are in the era of evidence-based policy, and the evidence comes from researchers. So once again, I want to thank the University of Science and Technology and the organizers of this conference for letting us be part of this conference. And we are learning, we are listening, we are committed to putting the evidence into practice. I thank you.
Join us together as we usher these two important gentlemen back into their seats. Thank you, thank you. When research meets practice, what term do we call that kind of interaction? Let me see. Anyone who was here since, anyone who has been here since morning? The Ghanaians. Prof. Kone, you can delegate someone to give us okay, yourself. Implementation science. Yeah, no wonder you're a professor of gynecology. When we see policy people coming in to engage with the researchers, we are very delighted, because when we have results coming through, which results are promising, they'll be able to find their way into policy. And that makes the scalability much easier. Professor Kazova, you've been seated here since break tea, and I know you're tired. Let me invite you to come and close this meeting for today. Let's welcome Professor Kazova. After today's talk, he's a graduate of AI. Yes, over to you.
I stand on the existing protocol, ladies and gentlemen. You know, when you are seated in the audience, like the way you are seated, sometimes it's very, very difficult to appreciate the audience. But when you get an opportunity, like those who have been standing here making presentations, and you stand here like the way I'm standing, and you look on your right like the way I'm doing, just look, you look the other side, you look on the left, that's when you appreciate the audience. On my part, you are an amazing audience. Wherever you have traveled, wherever you have come from, I don't know how many hours you took, how many kilometers you traveled, as Mbarara University of Science and Technology, we appreciate your time, we appreciate you being here, and above all, being attentive and contributing to the agenda of AI and how it impacts on health, because that is the main gist of this project. So we need to thank you for that. Number two, I want to use words which are not mine. These are words by Henry David, and I want to quote and read them verbatim so that I don't make any slight mistake. And I quote, "An early morning walk is a blessing for the whole day," end of quote. You can imagine an early morning walk is a blessing for the entire day, end of quote. Why have I said this? How have I, reminded myself of this exemplary, this quote, which I consider to be very, very interesting. When we reflect back, and I was reading on the documentation for this project, for this intervention, now I took minds backwards. I used my central processing unit, CPU, and I looked at the people. You can imagine I looked at the people who were behind this intervention, this project, and these are some of the names that came in my mind. Those ones who were there in the morning walk. And that's why we're here celebrating. And that's why it is a blessing, not only to Mbarara University of Science and Technology, but even to the community, to this country, to Africa, and the world. These are some of the names that came into my central processing unit. And if I were to call the names, you would say present. Joseph Ngonzi, present. Fred Kagwa, present. Jessica, present. Rogers Mamvu, present from Ghana. Connie, present. Leo, to mention here but a few. Thank you for being part of that morning walk. And the solutions which are tried to come up, you can imagine since morning, the solutions, issues which we have been discussing, and on how to address issues of health using AI. These are very interesting solutions. And it's because of those people who were there morning walk. Now, for emphasis, some time back, for example, in the 80s, sometimes in the 90s, and say, okay, for us in academia, I can mention here, for me, I didn't start in academia. My 17 years were in administration. That's where I started, in finance administration. Then I had to go for 15 years in academia. Now I bounced back to administration. But what I'm trying to say, in those 70s, 80s, I remember one time they would be in some of the meetings and they would say, either you publish or you perish. But now we are in the 21st century. It's not publication that is very, very important. Either you perish. And thank you. All of you are here for networking. Because if you network, it's a multiplier effect. It increases the visibility, let us say, of Mbarara University of Science and Technology. Internationalization has got a multiplier effect to internationalization. Now you can imagine We have got friends from this morning walk, friends from Uganda. I know you are there. You're most welcome to Uganda. This is your country. We have friends from Ghana. We have friends from America. I don't want to mention other countries. I may make a mistake there. But the point is, either you collaborate. If you don't collaborate, for sure, you are going to perish. And thank you for that positive, for that tailored collaboration, that focus and that persistence of collaboration. And the collaboration which has been brought up by this intervention of AI and how it is trying to solve problems of health, that collaboration alone, it will increase the visibility of Mbarara University of Science and Technology. We have got many scientists who have been trained or who are going to be trained. And for your own information, the lectures, the presentations which I had when I arrived here up to today, I'm a different person as far as AI is concerned. And thank you for that collaboration. My third point, remember I was not on the agenda. Others were using 10 minutes, so I should use less than 10 minutes. My third point is that, and these again are words which are not mine, this has been a symposium, it's a workshop, it's for... Let me quote these words by David Linley, and I quote, "The workshop to me always means great atmosphere. Working, smelling of wood, dust, and at the end of the day, you have created something." End of that quote. From morning up to now, we have created something. You can imagine the panels which were in front here, how they were really responding to the questions and the comments. I don't call them questions, they are comments which are coming from the audience. These were excellent comments. And the responses, just earlier on when I was seated and some of the things were being mentioned, then I was reflecting on my other works. I said, oh, it's not only the takeaways that you find in the restaurants or any other takeaway, restaurants and the rest of it, but sometimes in academia, by the way, not sometimes, always in academia, when you sit here for 10 minutes or 30 minutes or whatever number of minutes you are here, then you ask yourself, what is my takeaway? I know there is some takeaway, according to me, which I have gone with to learn from these excellent scientists, and we need to thank you. Let me end my comments on a lighter note. Mbarara University of Science and Technology is known for science, is known for technology, is known for community engagement, what we call community-based education, research and service. Whatever we do, it has to impact the community. Now, to us, as Mbarara University of Science and Technology, everything that comes on board, be it a project, be it an intervention, be it a lecturer coming to Mbarara University of Science and Technology, being a visiting professor and the rest of it, if you cannot talk the language of science, you cannot talk the language of technology, you cannot talk the language of community engagement. For goodness sake, it's not in football where they use red cards or green cards or yellow cards. But if you are not talking about that, we have to give you a yellow card, or sometimes to the extreme, we give you a red card. Now, for this intervention, when we are talking about AI, it is integrated with the mandate of Mbarara University of Science and Technology, science and technology, because when we are talking about AI, that is innovation, that is technology. So on behalf of Mbarara University of Science and Technology, I'm pulling out You know, sometimes you always see yellow or red cards, but remember there is a green card somewhere. I can as well say it's the carpet or whatever, but there is a green card somewhere. So because of the discussions which have been going on board science and technology, to the team leaders, principal investigators, co-investigators, and team participants, on behalf of Mbarara University of Science and Technology, today I'm pulling out a green card, not a red card, not a yellow card. With those many words, ladies and gentlemen, you are invited on behalf of Mbarara University of Science and Technology for a cup of tea. Thank you.
Ladies and gentlemen, let's remember that tomorrow we are here for the village. Remember, community engagement, implementation science, and networking. Let's keep time tomorrow. We promise to start on time. Thank you so much, ladies and gentlemen. Let's go for a cup of tea, meet and greet, and network.